everyone. A very good evening to all of you. I welcome you all for today's session. Hope you all are doing well. I am Dr. Priyanka Sachdev here, and today we all are gathered here to study a difficult topic in pharmacology, that is pharmacokinetics. So I hope I'm clearly visible, audible to you guys, right? If I'm clearly visible, audible, you can write down in the chat box. If everything is good to go, we will start the session. I guess it's great. Okay, good evening everyone. So today we will discuss the important topic in pharmacology which most of the students find difficult, and many students demanded me to take this topic on YouTube. So we are going to discuss entire pharmacokinetics in one shot. Okay, so most of the students think that this topic is more of mugging, but I will change your perception after 2 to 3 years. I will ask you the same question. Is it pharmacokinetics still mugging? I will change your perception. It is entirely a conceptual topic. So I will make this topic a cakewalk for you. So it's a very scoring topic. Whatever exam you are preparing, if you're a second prof MBBS student and you are preparing for your university exams of pharmacology, and if you are preparing for any of the competitive exam like NEET, PG, FMG, INICT, USMLE, so this topic is really very important. And many of the numericals also come from this topic. As the topic is lengthy, without wasting any further time, I must start it. So let me share my screen with you people. I guess you can see my screen. So we can start. Okay. Can we start? Okay. So let's start the topic. Let's start the topic pharmacokinetics. So let me explain you. Let me start from the beginning, from the scratch. Okay. What is pharmacology? Start from the beginning. Pharmacology is the science, it's the study of the drugs. It's the study of the drugs. In the pharmacology, we are having two branches, pharmacokinetics and pharmacodynamics. So today we are going to discuss pharmacokinetics. I will call pharmacokinetics as PK and I will call pharmacodynamics as PD. So let me explain what do you mean by PK and what do you mean by PD. What do you mean by pharmacokinetics? What do you mean by pharmacodynamics? Let me explain you and then I will start the details of the pharmacokinetics. And next session, I'm going to plan complete pharmacodynamics in one shot. But next session, today we are going to discuss complete pharmacokinetics in one shot. Okay, so let's start it. So listen, just suppose why we take drugs. Why we take drugs? By drugs, I mean medicine. Why we take medicine? Whenever we fall ill. So whenever any patient is coming to us, we are doctors, we prescribe drugs to the patient, we prescribe medicines to the patient. Why? Because the patient is having certain disease, some or the other disease. And to cure the disease, to treat the disease, to control the disease, we give medicines to the patient by various routes. For example, I'm having certain problem. Okay, I'm having certain disease. For example, I'm having headache. I'm having migraine. I don't have it, but for example, I'm having it. And I'm coming to you that doctor, I'm having headache. I'm having migraine. You are prescribing certain medicine to me, ma'am. Please take this medicine via oral route in the form of the tablet. You should take it. Okay, so I am taking the drug by mouth. Okay, so by oral route, the most common route, the most convenient route, the cheapest route we take. So we are taking the drug. The patient is taking the drug. You can see on the screen by mouth. You have to understand this master diagram. I will explain you complete pharmacokinetics in this master diagram. So please understand from the basic. So the drug is going in the mouth, then it is going in the esophagus, then it is going in the stomach and the intestine. You can see the complete pathway. Now the drug has to be absorbed. What do you mean by absorption? The first thing, the body has to absorb the drug. So absorption is the movement of the drug from the site of administration to circulation. Circulation is the blood. So drug has to be absorbed. So from where the drug will be absorbed? So there is a rule. There are two types of drugs, acidic drugs and basic drugs. Weak acids, weak bases. So there are two types of drugs. Now whatever drug I am taking, maybe it is an acidic drug or maybe it is a basic drug, depending. Okay, so I will give you a list also which drugs are acidic, which drugs are basic later on. Okay, so there is a rule. Acidic drugs are absorbed from acidic medium and the basic drugs are absorbed from basic medium. We know stomach have acidic medium. This is stomach. And we know intestine have basic medium. This is intestine. So my point is that acidic drugs are absorbed from stomach and the basic drugs are absorbed from intestine. You may be thinking, why? Why, ma'am? Why acidic drugs are absorbed from acidic medium and basic are absorbed from basic medium? Why it is like that? I will explain you everything. Give me few minutes. I will come on this explanation also. Okay, I will come on this explanation also. Okay, but please understand. So acidic drugs are absorbed from acidic medium and basic drugs are absorbed from basic medium, and this is known as absorption. So first step is absorption. Absorption. What is the definition of absorption? Say, ma'am, it's the movement of the drug. From where to where? It's the movement of the drug from the site of administration to circulation. So it is not always we are giving the drug by oral route. Maybe we are giving by subcutaneous route, transdermal patches. There are various routes, no? IV route, transvaginal route, rectal route. So by whatever route you are giving, IM injection you are giving, so ultimately it will reach into the blood, and that portion is known as absorption. That step is known as absorption. After absorption, the drug is in the blood. Okay, the drug is in the blood. Now the drug will go to its site of action. Via blood, it will go everywhere. From head to toe, it will go everywhere via blood. Now, each drug has certain receptors on particular organ. Now, if I'm having the headache, I'm having the migraine, and you are prescribing certain drug to treat that, to cure that, to control that. So ideally, the receptor for that drug, which you are giving to me for the headache, the receptor for that drug should be in the cranial blood vessels or in the brain parenchyma. So that drug via blood go everywhere. But since the receptors are present here, it will act here only. So different drugs have receptor in different organs. If I'm having diarrhea, or I am having constipation, you are giving certain drug to me. So the receptor for that drug will act on the intestine. If I am having bradycardia, tachycardia, heart failure, and you are giving certain drug for that, so the receptor for that drug will be in the heart. So receptor can be any of the organ depending on the disease. So the drug will move to its site of action depending on the receptor. Where are the receptor for that drug? So drug will move to its site of action, and after going in the site of action, drug will show its mechanism of action. Drug will show its mechanism of action. Drug will control the disease, cure the disease, treat the disease, whatever it will do. It will show its mechanism of action. Okay, got it. Now, drug has done its job. Whatever it was supposed to do in the body, it has done that. If you have given a drug to me for bradycardia, it has already treated it. Now, I cannot keep it in my body forever. I want to excrete the drug. So for excretion, the drug will go to the kidney and ask the kidney, can you excrete me out of the body? I have already performed my function. So kidney is saying, no, I cannot excrete you. No. So drug is asking, why you cannot excrete me? So the kidney is saying, because you are a non-polar drug. And from kidney, the urine comes out. The drug will be excreted in urine. What is urine? Urine is water. My point is that only polar drug, water soluble drug will be excreted in urine. Non-water soluble, that is non-polar drug, cannot be excreted in urine. Common sense. So before excreting, we have to convert a non-polar drug to polar drug. Got my point? We have to make it water soluble. Water insoluble to water soluble. Then only it will be excreted in urine. Urine is water. Got it? So kidney is asking the drug, can you please convert from non-polar to polar? Then come to me, then I will excrete you. So this is how the things go. Okay. By the way, when the drug moves from the blood to its site of action, this is known as distribution. This is known as distribution, the second step. So first step was absorption, when the drug is moving from administration to circulation. Then from circulation to site of action is distribution. The movement of the drug from circulation to site of action is distribution. Now after distribution, drug want to get excrete, but it cannot excrete because the drug is non-polar. And we want to make it polar. So the drug will go to the liver and request the liver, can you please convert me from non-polar to polar so that I can excrete from the urine? So liver is saying yes. Come inside me. Inside me there is hepatocyte. In the hepatocyte there are enzymes. Most common enzyme is CYP450, cytochrome P450. Come inside me, my hepatocyte, my enzyme will convert you from non-polar to polar. So drug will enter inside the liver, and in the liver it will get converted from non-polar to polar. This step is known as metabolism. Metabolism or biotransformation, the third step. So the first step is absorption, then distribution, then metabolism or biotransformation, one and the same thing. And finally the drug now polar. The drug is now converted to polar. Now drug will go to the kidney. Kidney, now you will excrete me. I'm already polar. So kidney will say yes. And final step is excretion. Excretion is excretion of the drug out of the body. So there are 4 steps. What the body is doing on the drug. Body is doing 4 things on the drug. What 4 things? You tell me. First, body is absorbing the drug. Then body is distributing the drug. Then body is metabolizing or biotransforming the drug. And then body is excreting the drug. The 4 things body is doing on the drug. So what do you mean by the 4? Can you define the 4? What is absorption? Say, ma'am, absorption is movement of the drug from site of it. We will see in another diagram. Okay, this is absorption. Patient is taking the drug. It's going inside in the stomach and in the intestine. It will get absorbed into the blood. It will get absorbed and reach in the blood. This is absorption. What is absorption? Absorption is movement of the drug from the site of administration till circulation. This is absorption. Learn the rule. Acidic drugs are absorbed from acidic medium and basic drugs are absorbed from basic medium. So acidic drugs are absorbed from stomach and basic drugs are absorbed from intestine. Why? I will tell you later on after a few minutes. Okay. So this is absorption. Okay. After coming in the circulation, drug will move to its site of action, and this is known as distribution. I will show you a video also. This is distribution. After showing its mechanism of action there, drug want to get excreted, but it cannot excrete. So drug will go to the liver and get converted from non-polar to polar. This step is known as metabolism or biotransformation, and finally the drug get excreted. So body is doing 4 things on the drug, and that is known as pharmacokinetics. That is known. Drug is doing only one thing on the body, that is mechanism of action, and that is pharmacodynamics. So what the body does on the drug, that is pharmacokinetics, PK, which I am teaching you today. I will teach you 4 chapters: absorption, distribution, metabolism, excretion. One by one we will deal with 4. First understand the basic, and what the drug is doing on the body, that is mechanism of action, is pharmacodynamics. That I will take another session. How drug acts, that is mechanism of action, that is pharmacodynamics, that we will deal in another session. So first you tell me, what is pharmacokinetics and what is pharmacodynamics? Yes, definitely PDF will be provided after the session. First concentrate here. Okay, what is pharmacokinetics? What is PK? PK, pharmacokinetics. And what is pharmacodynamics? PD, you tell me. Pharmacokinetics, what the body does on the drug. Body absorb the drug, distribute the drug, metabolize the drug, and excrete the drug. You know the definition of all of them. I guess you can understand now. What is absorption? Movement of drug from site of administration to circulation. What is distribution? Movement of drug from circulation to site of action. What is metabolism? Metabolism is conversion of non-polar drug to polar drug, mainly happens 99% in liver. And excretion is elimination of the drug out of the body, that occurs in kidney via urine. So the 4 steps, what the body is doing on the drug. In exchange, what the drug is doing on the body, the drug is showing its mechanism of action on the body. That's it. So pharmacokinetics having 4 parts. Pharmacodynamic have only 1 part. The 2 branches of pharmacology. Pharmacokinetics, what the body does on drug. And pharmacodynamics, what the drug does on body. Okay, how to learn? The mnemonic is very simple. D for D. Pharmacodynamics, D for drug. The drug is doing on the body. D for D, you can learn like that. So here we are having 4 branches. 1, 2, 3, 4. No need to learn any mnemonic. It's absorption first, then distribution, then metabolism or biotransformation, one and the same thing, and finally excretion. You can learn the mnemonic ADME if you wish. And here only one thing, mechanism of action. Any confusion? If you have any confusion right now, please ask. I will show you a video, the 4 steps in a video. Please concentrate. I'm going to show you. See here, the first drug is coming from the site of administration to circulation. This is absorption. Now from here to it is going to its site of action. It is known as distribution. And then it is going in the liver, getting converted from non-polar to polar, and finally get excreted. How many of you got it? How many of you got it? You want to see it again? Try to concentrate on the 4 steps. Okay. First, from the site of administration, it is coming to circulation, absorption. Now from here, circulation, it is going to its site of action. That is distribution. Then from circulation, it is going to liver, getting converted from non-polar to polar. That is metabolism. And finally getting excreted out of the body. So these are the 4 steps. So that is absorption. See, it is absorbed. Then it is distributed in various organs depending on the receptor distribution. Then it will get metabolized. See, it is going inside the liver and converting from non-polar to polar. Metabolism, and finally excreted out of the body. So I hope everyone got. And this is pharmacodynamics, the mechanism of action. So mechanism of action is pharmacodynamics, that we will deal in another session. Everyone give me a thumbs up if you got it. Everyone. Okay. Is it? Can we go ahead? So we will solve some questions based on this basic, and then we will start our chapter pharmacokinetics. Okay. So read the question and write your answer in the comments right now. Read the question. What is pharmacodynamics? Pharmacodynamics deals with PD. What is PD? Is it effect of drug on body or effect of body on drug? Or is it absorption of drug? Or is it metabolism of the drug? What do you say? Out of ABCD, what is the correct answer? Write down in the comments, please. Okay. Water in urine, polar drugs will be dissolved. Non-polar cannot be dissolved. So we have to convert the drug from non-polar to polar so that it can dissolve in the water, that is urine, and get excreted out of the body. Everyone got it? What is the correct answer? Please tell me now. Yes. So what is pharmacodynamics? D for D. It is the effect of drug on the body. Absolutely right. The correct answer is A. And if I change the question to pharmacokinetics, answer will become B. B also, C also, D also. In pharmacokinetics, everything else is there. Okay. Now read the next question. Pharmacokinetics include all of the following except. The question contains except. Please read the 4 options. Absorption, distribution, adverse effect, excretion. What is not included in pharmacokinetics? I told you, no, pharmacokinetics have 4 branches. What are the 4 branches? Absorption, yes, it's there. Distribution, yes, it's there. Excretion, yes, it's there, but adverse effect is not there. Instead of adverse effect, it's distribution. So correct answer is C, because adverse effect is not included in pharmacokinetics. I hope you all are right. So very easy questions are asked here. Okay, it's a basic. I guess everyone knows that. We are just brushing up your concepts. Pharmacodynamics includes what? What is pharmacodynamics? Is it drug elimination? Is it drug excretion? Is it drug absorption? Or is it mechanism of action of the drug? I told you pharmacodynamics have only one branch. Only one thing. Only one thing inside that. What is that? Is it elimination, excretion, absorption, or mechanism of action? PD includes what? So you all are right. Absolutely right. The correct answer here is D, the mechanism of action. So pharmacodynamics means mechanism of action. You all are right. So pharmacodynamics have only one thing, the mechanism of action. I hope you are absolutely right. So let's start the chapter now. I hope you got the basics and you got the master diagram. If you got the master diagram, now I am going to teach you 4 things today. We will discuss pharmacokinetics completely today. First chapter, I will deal with 4 chapters today only. First chapter, I will deal with absorption. It's a small portion we will deal. Distribution is difficult to understand, but I will try my best. Then metabolism, and finally excretion is very difficult and you get many numericals from this portion. So we will discuss four things one by one, the complete pharmacokinetics. Let's start with absorption. Can I start absorption? By the way, I'm going to teach you everything in the master diagram. I hope everyone got the master diagram. Okay, in this only we will understand everything. Let's start with absorption. So we have already seen what is absorption. Absorption is the movement of the drug. From where to where? From site of administration to circulation. The movement of the drug from the site of administration to circulation. It is known as drug absorption. What are the factors? There are many factors on which drug absorption depends, but mostly the question comes on the pH. What is the effect of pH on drug absorption? What is the effect of pH on drug absorption? I told you acidic drugs are absorbed from acidic medium and basic drugs are absorbed from basic medium. Now I will explain why it happens. Why acidic drugs are absorbed from stomach only and why basic drugs are absorbed from intestine only. I will give you a reason, valid reason for that, and we will discuss the numericals, formulas, everything. So one of the important factor on which absorption depends is the pH, of the medium. Okay, actually pH decides the ionization of the drug. Let me explain. Okay, so let's start it. Ionization and the pH. There are 2 types of drugs. Non-electrolyte. Some drugs are non-electrolyte and some drugs are electrolyte. If they are electrolyte, again they are of 2 types. Some drugs are strong electrolyte and some drugs are weak electrolyte. If the drug is non-electrolytes, its absorption do not depend on pH. It's not at all pH dependent. It depends on lipid solubility. If the drug is lipid soluble, it will absorb. If it is not lipid soluble, it will not absorb. But if the drug is electrolyte, at all pH, again, strong electrolytes in the chemistry we have read, they ionize at all pH. So again, this one is not dependent on pH. This one is not dependent on pH. This one, the weak electrolyte, depends on pH. And unfortunately, most of the drugs are weak electrolyte. That's why their absorption depends on pH. So this is the basic you must understand. So the same thing, non-electrolytes drug do not depend on pH. And among the electrolytes, strong electrolytes also do not depend on pH. It is the weak electrolyte which depends on pH. And most of the drugs are weak electrolyte. So their ionization depends on pH. Now, there are 2 types of weak electrolytes, acidic and basic. I mean to say weak acid and weak base, because we are talking about weak electrolyte. So there are 2 types of drugs, weak acid and weak base. What is the acid? Have you seen any acid? HCl, HNO3, H2SO4, these all are acid. My point is that all acid contain proton. Have you read this in chemistry? This is a proton, this is a proton, this is a proton. So let's make a general formula of acid, HA. A can be anything. A can be Cl, NO3, HSO4, it can be anything. But proton is compulsory. So the formula of acid is HA. What is the base? What is the formula of base? Let's say some bases. So NaOH, okay, KOH, okay, CaOH twice, likewise. So all the bases contains hydroxyl ion, OH. OH is compulsory. That is hydroxyl. So let's say the formula of base is BOH. B can be anything. B can be Na, B can be K, B can be Ca. This is chemistry. Basically, we have read this. So HA and BOH. So HA is the acid, basically weak acid. And BOH is the base. You can understand that. Okay, now please understand this topic is difficult. I will tell you the summary. Okay, I will explain the complete derivation like mathematics, and in the end I will tell you the summary. If you can understand the derivation, it's good, but if you can't understand, it's okay, we will learn the summary. So both ways we will go. Okay, now please understand. I will prove why acidic drugs are absorbed from acidic medium only and basic drugs are absorbed from basic medium only. I will explain and I will prove that why. That's what, with the help of a mathematic derivation, we are going to prove it. So acidic drugs are HA and basic drugs are BOH. Okay, so we have derived a formula. Now listen, how does HA ionize? H positive, A negative, like HCl, H positive, Cl negative, like HNO3, H positive, NO3 negative, likewise. So two ions are formed. Likewise, the base also dissociate B positive and OH negative. So we have the ions. So this is known as ion. Now where is the drug? You tell me, where is the drug? So listen. See the acid. The drug is in two forms. This is the drug. HA also contains A and A negative also contain A. So drug is in two forms. This is known as unionized form, that is complete. And this one is known as ionized form, which is having a charge on that. And similarly base also. So this BOH is the drug and B positive is the drug. So this one is unionized, this one is ionized. So whether the drug is acidic or basic, it is having two forms, ionized and unionized. You got it? What is the ion? Ion is anything having charge on that. So this one is ion, this one is ion, and these two are unionized form. Now learn the golden rule. You have to learn a rule. The rule says that body retains unionized form and body don't like ions. Body don't like charges. Human body excrete charges. If I'm having any charge in my body will excrete that. So ions are excreted out of the body. Body don't keep charges. Body excreted. But the complete form, which don't have charge on them, the unionized form, body absorb it. For absorption, we require unionized form. And for excretion, we require ionized form. How many of you got it? How many of you got it? So please learn the golden rule. Now, if you got the golden rule, have you read this formula? This formula in chemistry in your childhood, whenever you are in 7th, 8th standard of your school. I guess we all have read this. The formula of pH. What is pH? pH is equal to pKa plus logarithm of ionized form upon unionized form. You can see ionized is the numerator and unionized form is the denominator. So what is the formula? pH is equal to pKa plus logarithm of, what is the logarithm of? Ionized form upon unionized form. This is the formula. What is pK? Can anyone tell? Can anyone is expert in chemistry in your childhood? What is pK? Let me define it. Let me imagine we take an acidic drug. Let's talk about acidic. Forget the basic right now. Take acidic drug. Where is the acidic drug? HA. Ionize it. How it will get ionized? Same, very simple. H positive and A negative. So apply it here. Imagine out of the total 100% drug, 50% is as it is and 50% get ionized. It can be any percentage. I'm just assuming it is 50-50. It can be 10-90, it can be 90-10, it can be 50-50, it can be anything. Okay. Currently, I'm taking an example 50-50. So I'm saying ionized is also 50% and I'm saying unionized is also 50%. They will cancel each out. 50-50 cancel. So log 1. What is log 1 by the way? Mathematics pada hai? Have you read mathematics in your childhood? Log 1 is equal to 0. I guess everyone know. So in that case, pH is equal to pKa plus 0. Log 1 is equal to 0. So I can say pKa is the pH at which drug is 50% ionized and 50% unionized. It's a very important MCQ in your exam. What is pK? Can you define pK? What is pK? pK is a constant, but we define it like this. Bisma, we define it like this. So what is pK? Say, ma'am, pKa is the pH at which drug is 50% ionized and 50% unionized. That pH is known as pK. And I have proven that. I'm not asking you to learn, to mug. I have proven that with the help of formula. So this is how we learn pK. You got it? So the same story is written in front of you. Read it. pH is equal to pKa plus logarithm of ionized upon unionized. Let's say both of them are 50-50. So keep it 50-50. So cancel each out. Both of them are equal, so they are cancelling. So log 1 is equal to 0. When they are cancelling, log 1 is equal to 0. So pH is equal to pK. So basically pKa is the pH at which drug is 50% ionized and 50% unionized. It's a very important MCQ, repeatedly asked MCQ in your exam. Now, let's come on the main point. Okay, you know 7 is the neutral pH for water. We know. Now, if I increase the pH, like if I'm increasing by 1 unit plus 1, it will be 8, it will be 9, it will be 10. So it is alkaline medium. And if I'm reducing the pH by 1 unit, 2 unit, 3 unit, I mean 6, 5, 4, 3, 2, 1, it is acidic. So from the neutral, if we are increasing the pH, it's alkaline. I guess everyone knows. And if we are decreasing the pH, it's acid. Okay, because I will use this form concept. That's why I'm just revising you. Okay, so reduction in pH is acidic. We are going towards acid. And increase in pH, we are going towards alkaline. Okay, now what is the formula? What is the formula? Okay, listen. In the same formula, this is the formula. First, I will increase it by 1 unit and then I will reduce it by 1 unit. First, I will make it alkaline and then I will make it acidic. For example, I want to increase it. pH is equal to pK. pH is equal to pKa if I take these two equal. But currently, I'm not taking it. I want to increase it by 1 unit. So when this will be 1, not 0. I want this thing to be 1. I do not want 0. If I want 0, I have to keep the two things equal, ion and anion, ionized and anionized. So they cancel out. So log 0 will be, log 1 will be 0. But I want the answer as 1. So I want to ask you, what should be this ratio? So you know log 10 is equal to 1. Log 10 is equal to 1. You know that or you don't know? I guess everyone knows. And log 1 by 10 is equal to minus 1. You got my point? So I want two things. You tell me what should do. What should we do? I want two things. I want to increase the pH by 1 unit. And here I want to reduce the pH by 1 unit. See, please understand. Here I am increasing the pH by 1 unit. Here I am reducing the pH by 1 unit. Here I am increasing means I am making it alkaline. And here I am reducing means I am making it acidic. So if I want plus 1, this value should be 10 by 1. So this value that is ionized upon unionized should be 10 by 1. And if I want this value to be minus 1, this value, the same value, ionized upon unionized should be 1 by 10. I hope you got it. How many of you got it? What I said? Now listen. So whenever I am making the medium alkaline, ionized form increases. And whenever I am making the medium acidic, unionized form increases. And we know body retain unionized form and body excrete ionized form. You got my point? So basically in alkaline medium, it is excreted. And basically in acidic medium, it is absorbed. So I have proven that acidic drugs are absorbed in acidic medium. Nobody is going to ask you this derivation. This is for your understanding. This is for your understanding. So nobody is going to ask you. Okay, I have just proven it for you. The same concept we will apply for basic drugs. So learn the summary. Come on, the summary. So this is just for the anxious students, and you know some students ask him, why? You explain everything. So for them I have explained. Nobody has asked you the derivation. Please learn the summary. Please have a look on the screen now. Whether you got it till now, it's good. You didn't got it till now, it's double good, I say. Okay, learn the summary. So you are going to get the questions from the summary. Listen. What the summary says. There are two types of drug. Okay, I'm having headache, for example. And you are a doctor, you are saying, ma'am, take this drug. Your headache will be all right. Okay, I'm taking the drug. Now, it can be acidic drug, it can be basic drug. Maybe it is a weak acid, maybe it is a weak base. I don't know. So I'm taking it. So the drug is going inside. Okay, now if it is acidic drug, it will be absorbed from acidic medium. And if it is a basic drug, it will be absorbed from basic medium. That is the rule. For absorption, same medium is required. Learn the rule. For absorption, same medium is required. Same medium. Acidic are absorbed in acidic medium and basic are absorbed in basic medium. That is the rule. That is the rule. If you ask the detail, ma'am, why it happens? Because in acidic medium, unionized form is more. Acidic drugs are more in unionized form in acidic medium. And basic drugs are more in unionized form in basic medium, and unionized form is absorbed. I want more and more unionized form. Got my point? Now the drug reach here. Drug has already shown its mechanism of action. Drug is already metabolized. Now I want to excrete the drug. For absorption, we have two organ. Acidic drugs are absorbed from stomach, and basic drugs are absorbed from intestine. Two different organs are there. But for excretion, we have one organ. The name of the organ is kidney. So whether it is acidic drug or whether it is basic drug, it has to be excreted from the kidney. Learn other rule. For excretion, opposite medium is required. We want to excrete acidic drug, make the urine basic. And you want to excrete basic drug, make the urine acidic. So the point is that if for absorption, same pH is required. And for excretion, opposite pH is required. This is the golden rule. Please learn that by heart. Please learn this. So acidic drugs are absorbed from acidic medium and basic drugs are absorbed from basic medium. This is for absorption. But if you talk about excretion, acidic drugs are absorbed in basic urine and basic drugs are absorbed in acidic urine. So you may be thinking, ma'am, you may be thinking, yes, this time we have to make it more and more ionized because body excrete ionized form. Absolutely right, Gauri. Listen. You may be thinking, ma'am, why we want to excrete the drug? Okay, listen. Being a doctor, let me ask you a question. You are a doctor. Okay, of course you are a doctor. We all are doctors. What do you want for the patient? You want the drug to be absorbed or you want the drug to be excreted? First you answer, then I will tell you what I mean, why I'm asking this question. I will tell you the context. Being a doctor, what do you want? You want the drug to be absorbed more or you want the drug to be excreted more? What do you want? First you tell me. What do you want? Bisma, Jitin, Gauri, anyone? So can you tell me? You want absorption or excretion? Yes. So most of the students will say absorption. I know that. Most of it. But it is not always true. Listen. Let me take two scenarios. Just suppose I am your patient. So I will say, doctor, I am having headache. I am having diarrhea. I am having constipation. I am having bradycardia, heart failure, whatever. You are giving a drug to me. Ma'am, take this drug. Your disease will be all right. So you want more and more drug to be absorbed so that it shows its mechanism of action. In that case, you want absorption more. Imagine I have tried a suicidal attempt, although I will not do this. Imagine a teenage boy is there whose result is declared today and he failed. And he attempted suicide by taking multiple drugs, multiple tablets together, maybe some sleeping pills he has taken, and he's become unconscious. Now the parents have seen and parents have taken the boy to you. Doctor, please save my child. What do you want in that case? So you will ask what happened. So they are saying he has taken 100 sleeping pills together. Now can you please save him? So now this time you want absorption or you want excretion? You want more and more excretion. If you want to save the child, if you do more absorption, the child will die. Got my point? So it is not always necessary that every time we want absorption. In poisoning cases, in case of poisoning, we want excretion more. Got it? So the first question I will ask the caretaker or the parent who has bring the child to me, which tablet he has taken, name the drug. So they may be showing you empty strips that, or they will name it, he has taken this alprazolam or whatever sleeping pill, tranquilizer, he has taken 100 pills together, like that. So being a doctor, I must know, is it acidic drug or basic drug? The emergency drugs, for the emergency drugs, you should know, is it acidic or basic? If it is acidic, I will basify the urine of this person so that it is excreted. And if it is a basic drug, I will acidify the urine so I can save the child like that. So it will be excreted out of the body. Got it? Say yes if you all got it. Can we go ahead? Huh? Can we go ahead? Yes. So that is the thing. So in case of poisoning, the suicidal attempts, poisoning, when multiple tablets are taken together, we want excretion. So you should know the emergency drugs, as I told you. So barbiturate, you know what are barbiturate? The sleeping pills, the most common sedatives which we use for the patient. Barbiturates and salicylate. These are acidic drugs. So if the patient has the poisoning of these, alkaline the urine as fast as possible. And morphine, amphetamine, atropine, these are basic drugs. So if the patient have poisoning of these drugs, acidify the urine as soon as possible. So your next question should be, ma'am, how to acidify or basify the urine? Can I do that? Can I do that with my wish? Yes, being a doctor, you can do that. You can acidify the urine of your patient. You can basify the urine of your patient, depending what you want. So first thing, you should know what is the nature of the drug. So opposite you have to do. If the drug is acidic in nature and you want to excrete it, make the urine basic. And if the drug is basic in nature and you want to excrete it, acidify the urine. So how to acidify and basify the urine? The next question. If you want to basify the urine, basify means alkalinization of the urine. So just start the IV drip. We won't give anything oral. It's an emergency. We will start the IV drip. IV drip of sodium bicarbonate, NaHCO3, sodium bicarb. So we will start the drip of sodium bicarb. So urine will be automatically basified and acidic drugs are excreted. And if you want to acidify the urine, again start the IV drip. IV drip of what? You start the IV drip of arginine hydrochloride followed by ammonium hydrochloride. Arginine hydrochloride followed by ammonium chloride. If you are starting these two, the urine will be acidified. This we will do in case of basic drug poisoning. So if the patient have poisoning of acidic drug, if the patient have taken multiple acidic drug together, what you will do? You will basify the urine. And to basify the urine, you will start IV drip of sodium bicarb. If the patient have taken the poisoning, multiple tablets of some basic drug. So in that case, you have to acidify the urine. The page is gone. You have to acidify the urine by starting a drip of arginine hydrochloride and ammonium chloride. How many of you got it? So let me tell you the summary. Everyone on the screen, what we have learned? We have learned something. Listen. So we are taking the drug by mouth. You can see the patient is taking the drug by mouth. It's going in the esophagus, it's going in the stomach, and it's going in the intestine. The first rule we have learned that for absorption, same pH is required. So acidic drug is absorbed from acidic medium and basic drug is absorbed from basic medium. Ultimately, whether it is acidic or basic, drug reaches in circulation. So acidic drugs are absorbed from stomach and basic drugs are absorbed from intestine, two different organs. Okay, ultimately drug reaches here in the blood. Now the drug have already shown its mechanism of action. It is already metabolized. We want to excrete it. Now excretion ki bari aayi. We want to excrete the drug. So for excretion, the rule is that opposite pH is required. So if you want to excrete the acidic drug, make the urine basic. If you want to excrete the basic drug, make the urine acidic. So for excretion, opposite pH is required. So that is the rule. Now, if we talk in terms of ions, so learn another golden rule. Body absorb or retain unionized form. Body like unionized form and it retain it. Unionized, the complete form. And body excrete the charges. Body don't like charges. Body excrete it. Body excrete the ions. The ionized form is excreted. So let's talk the same concept in terms of ions. In terms of ions, can we talk ionized and unionized forms? So for absorption, same pH is required. We all know that. So basically, acidic drugs are absorbed in acidic pH. Why? Because acidic drugs at acidic pH, they are unionized. And basic drugs are absorbed in basic medium. Why? Because in basic medium, the basic drugs remain unionized and body retain the unionized form. That is the reason. Okay. And for excretion, opposite pH is required. If you want to excrete acidic drug, make the urine basic. If you want to excrete the basic drug, make the urine acidic. How to do that? You know that. Okay, but why? Because acidic drugs in basic medium, they are ionized and they are excreted. And basic drugs at acidic medium, they are ionized and body excrete ion. I hope the concept is crystal clear. Give me a thumbs up if you got it. That was a difficult concept, but I tried my best to explain you. So if you got it, we will solve certain questions. Everyone give me a thumbs up. Everyone who is live and got it. If you have any doubt, please write down clearly. Okay, otherwise give me a thumbs up. Please indicate that you got it. Give me a gesture. Oh, so read the question and tell me the answer. Read the question. Acetyl salicylate and phenobarbital, which is a type of barbiturate. Why both of them are absorbed from stomach? Why? Can you tell me the reason why these drugs are absorbed from the stomach, not from the intestine? The 4 options are in front of you. Why they're absorbed from stomach? Tell me the reason, people. Why? First, you decide, is it a weak acidic drug, strong acidic drug, or weak basic drug? First, you decide. Why these 2 drugs are absorbed from stomach? We are talking about absorption. We know for absorption, same medium is required. So stomach have acidic medium. So these are acidic drug. These are acidic. These are not basic. So rule out. It's not a basic drug. It's an acidic drug. And it is not strong acid. Strong acid do not depend on pH. It's the weak acid which depends on pH. So I'm left with 2 options. Both of them have weak acid. Now weak acid. At gastric pH, these drugs are non-ionized or ionized. We know body retain non-ionized form. Ionized form is excreted. Charges are excreted from the body. So it is non-ionic form. So my correct answer is A and you all are right. So this is how we apply the concept in a question. Knowing the concept is a different thing, but applying it in a question and coming on the correct answer, you should know the approach. So correct answer is A. I hope you all got it. Say yes if you all got it. Read the next question. Acidic drug is more ionized at. Very simple question. I'm asking acidic drug is ionized at which pH? Alkaline pH, acidic pH, neutral pH, or none of the above? I'm asking acidic drug is more ionized at what pH? Ionized, body keep ionized form or excrete ionized form? I told you body don't like charges. Ions have charges. So body want to excrete it. So basically I want to indirect way, I'm asking acidic drugs are excreted in which medium? Indirectly I'm asking that. So for excretion, opposite medium is required. So acidic drugs are excreted in alkaline medium. Again the answer is A. Say yes if you got it. Say yes. Yes, correct. So correct answer here is A and you all are right. Coming on the third question, the next question. What is true about the acidic drug? Can you tell me among the 4 options what is true? So about the acidic drug. So it is best absorbed in acidic medium or best absorbed in basic medium? Or it is not absorbed in acidic medium? Or it binds to alpha glycoprotein? What is the correct among them? So the question is about absorption. And for absorption, same medium is required. So acidic drugs are absorbed in acidic medium. So correct answer is again A. I hope you all are getting it. Yes. Okay. One more last question. Then we will move on the next concept. What is the best way to manage a patient with aspirin poisoning? The patient is having aspirin poisoning. What you will do? You will make the urine acidic by starting a drip of ammonium chloride, or you will make the urine basic by starting a drip of sodium bicarbonate, or you will treat the patient with N-acetylcysteine, or you will do a gastric lavage. What you will do? There is an emergency case. Patient has taken 100 pills together of aspirin. He want to do the suicide, or by mistake, or homicide, or whatever. There is a case of poisoning in front of you. You are a doctor. You want to deal the situation, the emergency situation. What you will do? You should know aspirin is acidic drug or basic drug. First you tell me. So aspirin is the acidic drug. You should know. So to excrete the acidic drug, we want to make the urine basic. For excretion, opposite medium is required. So we will basify the urine by starting the drip of ammonium carbonate. So correct answer is this. Now, if I change the drug here, now instead of aspirin, if I give you barbiturate, any of the barbiturate, phenobarbital or any of the barbiturate, answer will become A. So it depends which drug we are giving. So learn the examples, which drugs are acidic, which drugs are basic. Being a doctor, it's an emergency. You cannot Google at that time that this drug is acidic or basic. The emergency drug should be clear in your mind. This drug is acidic, this drug is basic. So to excrete it, do it opposite. You cannot do the blunders. So if you want to excrete the acidic drug, you have to make the urine alkaline. If you want to excrete the basic drug in your patient, you have to make the urine acidic. If you do the opposite, patient will die. More absorption will be there. Okay, you cannot afford that. So that's it. So let's go ahead. Let's start the next concept. We are done with one concept till now. So coming on the next concept, that is bioavailability. What do you mean by bioavailability? Listen. Patient is taking the drug by mouth. Okay. Just suppose we are talking about oral route only. The drug is going inside. For example, you are giving 100 gram of a drug. 100 gram. Okay, we are giving a dose of 100. So how much is reaching in the circulation? It is not necessary. It is 100%. It will never 100. It will be less than 100. It will never equal. Whatever dose you are giving by oral route, it will never 100% reach. No. So maybe it is 80 gram it is reaching. Maybe 50 gram it is reaching. So the fraction of the administered dose. You are administering the dose of 100 gram, for example. So whatever dose you are administering, the fraction of which is reaching the circulation, that is bioavailability. So bioavailability is never 100% in case of oral route. Now there is a route known as IV route. Have you heard about the intravenous route? What we do in intravenous route? We directly inject the drug in the vein. Okay, here we use cubital vein most commonly and we inject the drug directly here. Okay, IV route. So in IV route, we are injecting it directly in the blood. So here the bioavailability is 100%. So just suppose I am having 100 gram of drug in my syringe and I'm directly injecting in patient vein. So 100 gram is in the blood of the patient. So IV route bioavailability is 100%. But in oral route, it's never 100. If you are giving it with oral route, no, listen. I have not put the image. It will be never 100. For oral route, it's never 100. So oral route, it is always less than 100%. Okay. So what is bioavailability? It is the fraction of the administered dose that is reaching the circulation in unchanged form. So different routes have different bioavailability, but 100% is only of IV route. It's a very important MCQ and you can easily understand that. So IV route have 100% bioavailability. Say yes. Got it? And different routes have different, but oral route is very variable depending 5 to 100%. It can be never 100, it is less than 100. Maybe up to 99, but never 100. Now, why in oral route? You tell me why. This is IV route. In IV route, we are giving the drug directly in the vein. You can see we are giving the drug directly in the vein. So it is 100% obviously. But in oral route, it's never 100. In oral route, it's never 100 because of two reasons. Number one, absorption. Absorption is never 100%. So it depends on the food. Yes, someone is asking, na, what is the effect of the food? Okay. So, you know, some foods increases absorption, some decreases absorption. It depends from food to food. Like grapefruit or some fruit, they decreases the absorption. Some drugs increases the absorption. So we cannot comment on that. But absorption is never 100%. It is not we are giving 100 grams, so complete 100 gram will get absorbed. No. So some fraction is lost in absorption. So first reason is absorption. Absorption is never 100%. Up to 99% can be there, but it's never 100. Okay, so absorption means some drug is lost. Some of the drug is lost. That is number one. Number two, you know what is the blood circulation of the GIT? You know, from here, portal circulation is there. You know, from the GIT, from the stomach and the intestine, portal vein takes the blood first to the liver, Then from the liver, via hepatic vein, it will go to the heart, and from heart, it will come to the blood. For simplicity, I have drawn like this, that acidic drugs are absorbed from acidic medium, and it is not directly going in the blood. No, no, no. First, it will go in the liver. That is known as first pass metabolism. So the drugs first go in the liver, and from the liver, it will go to the heart, and from heart, by purifying, then it is coming back to the blood. So this is known as first pass metabolism. Listen, liver contain enzymes that metabolize the drug. So just suppose I'm giving 100 gram of the drug. Out of the 100 gram, 80 gram is absorbed. Now all the 80 is going to the liver. Now liver have the enzymes. From the 80 gram, 30 gram is metabolized by the enzyme. So 30 is again lost. So I'm left with only 50 gram. And that 50 gram is coming back to the blood. So bioavailability is only 50%. So I have given 100, but what is reaching in the blood, that is bioavailability, the fraction which is ultimately reaching the blood. So in IV route, the bioavailability is 100%. But in oral route, it's never 100. It's always less than 100. Tell me two reasons why it is less than 100. Two reasons why. Number one, drug is never 100% absorbed. Some fraction is always lost in absorption. Number one. And number two, first pass metabolism. What do you mean by first pass metabolism? From the GIT, the blood goes to the portal circulation. From portal circulation, it goes to the liver. Liver have the enzyme. Enzyme metabolize the drug. So some fraction is lost in first pass metabolism. Okay. Because of these two reasons, the oral bioavailability is always less than 100%. Say yes if you got it. Everyone say yes if you got it. Can we go ahead? So that is the meaning of the bioavailability. Okay, my next question. You can see this is first pass metabolism. I have shown you. So drug is taken by oral route. The drug is going in the stomach and in the intestine. So from the stomach and intestine, the drug is going to the liver. And liver is metabolizing a fraction of the drug. The remaining is going in the blood. So whatever we are giving, whatever coming in the blood, that is bioavailability. The same thing. From the GIT, first it goes in the liver, then it goes in the heart, and then it's come in the circulation. So some fraction lost by the liver enzymes that are metabolized. That is first pass metabolism. Now my next question to you. How to calculate, how you will calculate bioavailability of a drug? Can you calculate it for me? So you will say, ma'am, bioavailability is different for different routes. So I'm asking you to calculate bioavailability of a drug by oral route. For example, let's take a drug, experimental drug A. So I'm giving the drug to you. Say it's safe. This drug is safe. It don't have any side effect. I'm giving it to you. This is a drug A. Can you take it? You have taken it. Now I'm asking you a question, how to calculate the bioavailability. Can you do an experiment for me and calculate the bioavailability of this drug A by oral route? Can you please do this experiment? So you are having a subject with you. You are having a subject on which, just suppose I'm your subject and you are doing the experiment on me. So how you will use this drug in me and calculate the bioavailability by oral route? So you will ask me, ma'am, can you please take this drug with water? Can you take it with oral route? So I'm taking the drug. So immediately I'm taking the blood. After 5 minutes, you are taking my blood sample and you are looking how much blood is reached in my blood. So every 5 minutes or every 30 minutes at a frequency, you are taking my blood sample. You are collecting my blood sample in multiple test tube, maybe in 30 minutes, 1 hour, 1 hour, 30 minutes, 2 hour, 2 hour, 30 minutes, 3 hour, likewise, multiple samples. So what will be the graph? You will say, ma'am, if I'm giving, just suppose I am the subject and there is an experimental drug you have given me, ma'am, take this drug. I have taken the drug with water. So I have taken the drug with water. The drug is going inside me. Now maybe it is an acidic drug. Maybe it is a basic drug. If it is acidic, it is absorbed from stomach. If it is basic, it is absorbed from intestine. Ultimately, it is absorbed. So gradually the concentration in my blood, it will come in my blood. So gradually the concentration in my blood will increase with time. It will reach a maximum concentration. Okay. On the x-axis, I am taking the time. On the y-axis, I'm taking the plasma concentration. So if you check my plasma concentration, every half an hour, you are taking my blood sample and seeing in the test tube how much drug is reached in my blood. So you will find gradually it is increasing, making a peak, reaching a peak, and then the drug will show its mechanism of action. It will start excreting in the urine. So it will fall, and finally again it will become zero. So this is the graph you will get. So in your subject, you will get this graph. You will say, yes, ma'am, common sense. So if you are giving drug to any patient, so plasma concentration first will rise. This is the maximum concentration in the plasma. Then fall, because ultimately drug is excreted in the urine. It will never remain in the body forever. Of course, it will be excreted. So the concentration will fall. It will become zero. So you are getting this graph. Now take the area of this graph. You know how to calculate the area in mathematics. If it is a triangle, you can see the formula of triangle is half into base into height. In your childhood, you have read this. Yes. So whatever is the formula, I'm not interested in the formulas. Apply that and calculate the area. So area of this graph will give you the value of bioavailability. The area of this curve will give you the value of bioavailability. So if you want to calculate the bioavailability, make a graph. Make a graph between what and what? Make a graph between two things. What two things? Plasma concentration versus time. Plasma concentration versus time. Make a graph. So we have make a graph like this. Whatever is the shape, I'm not interested in the shape. Take the area. It is known as area under curve, AUC. Area under curve. So area under curve of this graph will give you the value of bioavailability, whatever is the percentage, by that route. So it is not necessary we are always calculating with oral route. Maybe oral route, the bioavailability is different. IM route, the bioavailability is different. Rectal route, transdermal patches, various routes. If you calculate IV, it is 100. And these all are less than 100. So maximum area is an IV route. You get many questions on this concept. How many of you got it? Huh? How many of you got it? No, Bisma, maximum concentration is not bioavailability. Maximum concentration is maximum concentration. It is in the blood. Bioavailability is the fraction which is reaching in the blood. Okay, it is the area under the curve. So here, AUC, area under curve, between two things. What is the curve between and between? Between plasma concentration versus time. So on one axis, we are taking plasma concentration. On one axis, we are taking time. Make a graph. So area under this curve. Can you see this area? It will give you the value of bioavailability. Now take the same drug. Okay, take the same drug. I'm having two humans. I'm having two subjects with me. This is a subject. This is a subject. Okay. These are two my subjects on which I will do the experiment. And I'm having a drug A. This is my drug. To this person, I have given the drug A by oral route. Oral route. Okay. Oral route. He has taken it with water. And this person, I have given the same drug A by IV route. I have injected it directly. And I'm calculating the graph. I'm calculating the graph of this also, graph of this also. The same graph. So what I will get two graphs. Here the patient is taking it by oral route, my one subject. Can you see? It is taking oral route. And here the patient is taking it with IV route. Can you see? We are giving the patient with IV route. Calculate the graph. So we got two graphs. Can you see? This graph. Can you see this graph? This graph, the area under this graph is IV for the same drug. And for the same drug, the area under this curve is oral. So obviously, you can see it very clearly. The area of this graph is less than the area of other graph, the other curve. Can you see the other curve here? The other curve is this. It already includes this one. So IV is always more than oral. IV is 100%. Oral is never 100%. So again, we can compare the bioavailability by various routes by this method. How many of you got it? So can you explain everything about the bioavailability? What is bioavailability? So we are done with first chapter, absorption. I have to teach you 4 chapters today. So absorption, everything, all the important points we have done. What is bioavailability? Can you define it? What is bioavailability? See, ma'am, bioavailability is the fraction. Fraction of what? Fraction of administered dose, which is reaching in the circulation in unchanged form. So if I'm taking a tablet of 100 gram, so how much is reaching in my blood? Ultimately, that is bioavailability. If I'm taking 100 and 50% is reaching in my blood, so bioavailability is 50%. So only one route have 100% bioavailability, that is IV route. Rest all routes have less than 100%, that we have learned. How to calculate bioavailability? We have to make a graph. Graph between what and what? These all are your MCQs. Plasma concentration versus time. We have to make this graph. So in this graph, the area under curve will give you the value of bioavailability. Say yes, people. Say yes. Okay, got it. So can we go ahead? Yes. So let's come on the next topic. Any confusion? If you have any confusion, please ask. Okay. What amount of drug reaching the circulation? Absolutely right. Okay. So let's come on the distribution. We are done with absorption. Let's start distribution. What is distribution? We have just completed absorption. I want to teach you 4 chapters of pharmacokinetics. Today topic is pharmacokinetics in one shot. We are done with absorption. Well, let's come on distribution. Relatively tough, but I will make very easy for you. I will try my best, I mean. So let's come on distribution. Listen. What was absorption? It is the movement of the drug from the site of administration till circulation. The drug is already in circulation. Now from the circulation, drug will move to the site of action. That is distribution. So how does distribution occur? It is delivery of the drug to the tissue. From the circulation to the tissue. From administration to circulation is absorption. And from circulation to tissue is distribution. So let's start distribution. How many of you got it? Let's start distribution. Listen. So as soon as the drug get absorbed, as soon as the acidic drug absorbed from acidic medium, the basic absorbed from basic medium, it is absorbed. So after going in the blood, listen, this is acidic drug absorbed from acidic medium. Please understand now. And basic drug absorbed from basic medium. Ultimately, the drug reaches in the circulation. Okay. Once the drug is in circulation, a fraction of the drug, this is known as free drug. A fraction of the drug bind with protein. This is known as bound drug. So a proportion is free drug and a proportion is bound drug, and there is an equilibrium between the two. There is an equilibrium between the two. So equilibrium between the free drug and the bound drug. So in the blood, we have two forms of the drug. You may be thinking, ma'am, which protein? Name the protein. With which protein? This blue color is the protein now, with which the drug is binding in the bound form. So this protein can be albumin, can be alpha-1 glycoprotein. I will tell you, if the drug is acidic, it is albumin. It will bind with albumin. Albumin is a protein. And if the drug is basic, it will bind with alpha-1 glycoprotein. So whatever protein it is, whether it is albumin or alpha-1 glycoprotein, this drug is known as bound drug because it is bound with the protein. So you will say there is free drug, there is bound drug. Now the question, and there is the equilibrium between them. The biggest thing, there is the equilibrium between them. Now you may be thinking, ma'am, which drug will go to the site of action? Is it free or bound? That is my question. That is my query. That is my concern. So free drug move to the site of action, bound do not move. Please learn. Free drug will move to the site of action, shows its mechanism of action. It is the free drug which goes everywhere. It is free now. It can go everywhere, but bound will not move. Bound will not move. It is the free which will go to the site of action and show mechanism of action. And after that, it is the free only. It will go to the liver and get metabolized in the liver. It get converted from non-polar to polar. It is the free only. And it is the free drug only. It will go to the kidney and get excreted out. It is the free drug only which moves in all the tissue. It is the free. It is the free. So as the free will go and show to the site of action, the free will go to the liver and show metabolism, and free will excrete it out of the body. So the concentration of free will fall gradually. You may be thinking, ma'am, then what is the use of bound? You are saying that everything is done by free only. Then why bound is there? I will say bound is a backup. It's a backup, you know. So as the concentration of the free drug will fall, the bound will convert into free gradually again and increases the concentration of free. So ultimately bound is giving the backup. It's always equilibrium now. The free will fall, the bound will convert into free. And it is the free only which is moving everywhere. Then again, the bound is giving a backup to the free. So it is like that. So ultimately both parallelly decline. First free decline, then bound will give a backup to the free, so bound will also decline. So parallel decline in both of them. How many of you got it? Say yes, I'm coming on all your queries. Yes, nephritic, nephrotic, I will take everything. Give me a few minutes. Let me finish this plasma protein binding. So this concept is known as plasma protein binding, PPB. So can you see? So after coming in the blood, okay, the drug is taken by mouth. I'm sorry, what is happening? The drug is, just a second. Give me a minute. I cannot use the pen. Let's try now. So the drug is taken by the mouth. Okay, the drug is taken by the mouth. It is absorbed either stomach or intestine. Ultimately, it reaches in the blood. So a proportion of this is known as free drug. A proportion of it will bind with the protein. Which protein? It can be albumin. It can be alpha-1 glycoprotein. If it is an acidic drug, it's albumin. If it is a basic drug, it's alpha-1 glycoprotein. So a proportion of it is bound with the protein. That is known as bound form. This is known as plasma protein binding, PPB of the drug. This form of the drug is known as PPB. The bound form is known as plasma protein binding. PPB and bound form is one and the same. So which drug will move to the site of action? It is the free drug. It will show its mechanism of action. Which drug will metabolize? It is the free drug. Which drug will be excreted out of the kidney? It is the free drug. So it is the free drug which is moving everywhere. So the concentration of free drug will fall. So the bound will give a backup. There is an equilibrium now. When the free will fall, the bound will convert into free gradually, and gradually the bound will also fall. This is how the things takes place inside the human body. That is the use of the bound, Rohit. That's what I'm telling you. The bound is giving a backup to the free. When the free will fall, because it is moving here, here, and here, so its concentration in the blood is falling. Hana, it is ultimately excreted out of the body. So bound gradually get converted to free because there is an equilibrium now. So bound do not move everywhere, but it gives a backup to the free every time. So this is the thing we have understood. Now you will thinking, ma'am, being a doctor, why it is necessary for me to understand all this? If I was at your place, I also think the same thing. Why you are telling me all these things? Being a doctor, I am a doctor. I will prescribe the drug to my patient. How it is concerned with the protein? How it is a concern for me? It is a concern for you. Let me explain why. Let me explain. So listen. I told you the protein is different. No, if it is acidic drug, it will bound to albumin, and if it is a basic drug, it will bound to alpha-1 glycoprotein. So learn the list of acidic drug. These all are acidic drug. At least emergency drug you should know. So barbiturate, benzodiazepine, NSAIDs, valproic acid, phenytoin. These are acidic drugs. That's why they will bound to albumin. And learn the list of the basic drug. Important, not all. The beta blockers and the anesthesia drugs, the lidocaine, bupivacaine. These are basic drugs. They will bind to alpha-1 glycoprotein. So please learn the distribution. Okay, please learn. Okay, now listen. Listen, please, everyone here. You may be thinking, what is the implication of this bound form? You are thinking that only. No, listen. So it is the free form which is active. It is the free form. It is active. The free form only will go to the mechanism. It will go to the site and show mechanism of action. The free form only will go to the liver and show metabolism. And free form only will go to the kidney and show excretion. As I told you. Bound form is inactive. It don't do anything. But it will act as a reservoir. It is neither metabolized nor excreted, but it is a reservoir. It will give a backup to the free. We have understood this. Now you may be thinking, ma'am, what is the onset and duration of action of various drugs? Now, if I take a drug, some drugs are very fast in acting. What is the onset? So just suppose I'm having a headache, and there are two drugs, drug A and drug B. I'm taking a drug A, within half an hour, my headache is gone. And if I'm taking drug B, it is taking 2-3 hours to get cure. So that is the onset. Onset is the time duration between we take the drug and it shows its effect. So some drugs have very fast onset and some drugs have slow onset. Who will decide the onset of the drug? And what's the duration of action? If I'm taking a drug A, for example, so I have to take the next drug after 12 hours. So because it will show its duration for the 12 hours. If I'm taking drug B, I have to take it every 6 hours. So that is the duration of action. So some have high duration of action, prolonged duration of action. Some have small duration of action. So who will decide the duration of action? So it depends on plasma protein binding. So here we come, being a doctor, we should know the plasma protein binding of various drugs so that we can guide our patient whether the onset is fast or slow and whether it is long acting or short acting. So in case of emergency, we will use these drugs. In case of non-emergency, we can use these drugs. You are getting my point. So being a doctor, we should know that. How it is related, let me tell you. Imagine a drug who is having extensive bound form. For example, bound form is 90% and free form is only 10%. Imagine a drug. Imagine. So you will say, ma'am, only 10% is going here. 10% is going here. 10%. So only 10% is showing mechanism of action. So less entry in the tissue. 90% remains in the blood only. Since 90% is in the blood only, it is having prolonged action. It will keep on giving the backup. So duration of action is very prolonged. And since only 10% is going to the tissue, so onset is also very delayed. So onset is also very delayed. Such drugs have delayed onset. You don't use it in emergency, but duration of action is very prolonged. Onset is also delayed. We don't use such drugs in emergency. The drug which have high plasma protein binding, we don't use them in emergency. Consider the reverse. Imagine a drug which is having less plasma protein binding. I mean, the bound form is very less. Take reverse. Bound form is only 10% instead of 90. Here the free form is 90%. Oh my God. If the free is 90, immediately it will move to the tissue and shows its mechanism of action very quickly. 90% is free. So here the onset is very fast. In case of emergency, we can use that. But here backup is not there. Backup is only hardly 5-10%. So here duration of action is very slow. So these are emergency drugs. So this is how, being a doctor, we decide which drugs are emergency and which are non-emergency. So it depends on the plasma protein binding. You tell me, what is the meaning? What's the meaning of both of them? You got it? Say yes or say no. Drugs which is having high bound form and low free form. The free drug is less and the bound drug is more. What will be the consequence here? You tell me what will be the consequence here and tell me the reverse. The drugs which is having less bound form and more free form. Free drug is more. What will be the consequence here? Here the free is less. We concentrate on the free. Free is less now. So onset is very delayed. Only free is going to the tissue, but bound is more. Now bound is reservoir. It will keep on giving the backup. So duration of action will be prolonged. Duration of action depends on the bound. Onset depends on the free. I hope you got this concept till now. Okay, because free is going to the tissue and shows its action. So it decides onset. But bound gave the backup. So bound decides the duration of action. I hope you are getting it. People respond if you are getting it. Yes. Now here, the free is very high. 90% is free. It will quickly move to the tissue and shows its action. So onset is very fast here. Onset is very fast because bound is high, free is high, but here bound is very low, hardly 5-10%. There is no backup. So duration of action is very less. So this is how we decide which drugs are emergency, which are not emergency. Being a doctor, we should know which drug is having free form more, which drug is having bound form more. That is known as plasma protein binding, the concept of plasma protein binding. Now, someone was asking among you, I have not seen the name, about the nephrotic syndrome. Imagine a patient is coming to my clinic. Okay, this is a patient. Patient is having certain disease. Okay, patient is having, for which I'm going to prescribe a drug to the patient. This is the treatment I'm going to give, a tablet. Okay, For example, patient is having migraine or patient is having diarrhea, constipation, whatever disease, for which I'm going to prescribe a drug. But I forgot to ask the patient, and patient also forgot to tell me that patient is having nephrotic syndrome, one of the nephrotic syndrome. It can be any nephrotic syndrome. Okay, so patient is having nephrotic syndrome. You will say, ma'am, does it matter? Yes, it matters. So always ask a leading question to the patient. Do you have any kidney disease? Patient don't tell you proactively. Many patients don't. So you have to ask the leading question. Are you pregnant? Do you have any kidney disease? Any other disease in your body? So if the patient is having nephrotic syndrome, what do you mean by nephrotic syndrome? What happens in nephrotic syndrome? The albumin which is present in blood is lost in the urine. You have read this in pathology, no? In nephrotic syndrome, the albumin is lost in the urine. So albumin, if it is lost in urine, so in the blood there is less albumin, no? Hypoalbuminemia. So in nephrotic syndrome, albumin is less in the blood. So in nephrotic syndrome, basically the bound form is less. Because albumin is less, there is no albumin, no bound form. Hardly any albumin, less bound form. And free form is very high. Free form is very high. So such drugs can cause the toxicity. So I'm not assuming such a high. So normally if the patient don't have anything, I'm assuming the free form is 60% and bound form is 40%. If the patient is healthy. But here the patient is having nephrotic syndrome. So bound form is hardly 5%, 10%, hardly 5%. Remaining 95% is free form. So instead of 60%, it's 95%. So patient can have toxicity. So I have to reduce the dose. So in a patient of nephrotic syndrome, I will reduce the dose. To normal healthy patient, if I give 100 gram, here I will calculate and I will give only 60 or 70 gram to such patient. So it will show the same effect as that of a healthy human because the free form will be more. This is the reason. How many of you got it? It is conceptual. How many of you got it, people? Say yes. Huh? So if the patient is having hypoalbuminemia in case of nephrotic syndrome, albumin is less. Less albumin. So less plasma protein binding. Less plasma protein binding. So bound form is less. Bound form is less. So free form is more. So free form is more. It will lead to toxicity. So always take care. If any patient have kidney disease, reduce the dose. Reduce the calculated dose. Whatever dose you give to a healthy human, reduce the dose in a patient with kidney problem, with any nephrotic syndrome. Otherwise, if you give the normal dose only, if you don't reduce it, that will cause toxicity at the same dose. How many of you got it? People respond. Keep on responding. How I will come to know that you got it or you? I cannot see you now. So please keep on responding. Now imagine another patient. Imagine another patient. We will do the reverse situation now. Listen, imagine another patient. The patient is having certain infection right now. And the patient is having acute phase reactant increased in the body. You know what are acute phase reactants? Have you read this in pathology? Acute phase reactants. Acute phase reactants are the substances which increase in the body during any acute phase, like any infection or any emergency. Imagine the patient is having heart attack, the patient is having severe shock or anything, any accident, any surgery, or patient is having severe infection, sepsis, like that. So in that case, all the acute phase reactants are increased. One of the important acute phase reactant is alpha-1 glycoprotein. I told you, there are two proteins. Acidic drugs bind to albumin and basic drugs bind to alpha-1 glycoprotein. Here, alpha-1 glycoprotein is increased. So the bound form will be more because the protein is more. So bound form will be more. So free form will be less. So here the drug will not show its action effectively. Here it is reverse situation. You have to increase the dose. So if I want to give a drug to a patient who is having acute phase reaction, I will increase the calculated dose. To normal patient, if I'm giving 100 gram, here I will give 120 gram or 130 gram to show the same effect. This is the reason. How many of you got it? How many of you got it? So if any patient is having any of the acute phase reaction in the body right now, for example, MI, surgery, neoplastic disease, rheumatoid arthritis, burns. So in that case, alpha-1 glycoprotein is increased. So bound form is more. So free form is less. So it is showing less effect. If you want the same action, you have to increase the dose. I hope you are getting it. Say yes. If you are getting it, say yes. So can I come on the next concept? Can I come on the next concept? The apparent volume of distribution. Is it good to go? So let's start the next concept. Apparent. Yeah, one more concept I have left here. Dialysis. You know what is dialysis? When we perform dialysis, in case of poisoning, whenever any patient is coming to me with a poisoning, taking 100 tablets together, tried suicidal attempt. Imagine a teenage boy, a 15-year-old age boy, and got the result of the 10th class. And he failed in that. And because of depression, he's committing suicide. So he has taken the sleeping pills and tried to take the 100 pills together. So it's an acute case of poisoning, right? So in such cases, you tell me dialysis is useful or not useful. What is dialysis? What is hemodialysis? We take the blood, we filter it, and we put it back. So we take the blood out of the body. And there is an instrument that is dialyzer. We put the blood in that. It will filter the blood. And again, we will resume the same blood into the body. So it's like, we are just filtering the blood and putting it back. That is the hemodialysis. So hemodialysis will be useful, yes or no? So it depends which drug the patient has taken in excessive amount. What is the poisoning is of? Now imagine a drug which is having the poisoning in which bound form is more. Here 90% of the drug is bound, only 10% is free. So you tell me hemodialysis is useful or not useful? You tell me. So you will say, no ma'am, in such cases hemodialysis is not useful, because when we filter, what is dialysis? In dialysis, there is a sieve-like structure. This is a sieve. This is a sieve-like structure from which the blood is passed. It don't hold protein. If it don't hold protein, you don't hold protein. So if you don't hold protein in the filter, so the bound form is not filtered. The bound form cannot be filtered out. So what is the use of dialysis if 90% of the drug cannot be held there? So don't use dialysis for the drug which is having high plasma protein binding. When the bound form is high, don't use dialysis. It is a waste of time, waste of money, waste of energy. Don't use dialysis in such cases whenever the plasma protein binding is high, because dialysis is not filtering the protein. It is of no use. For example, beta blocker is such a drug. So being a doctor, you should know that. Imagine at 2 o'clock in the night, you got a call from the nurse of the hospital. Doctor, there is an emergency poisoning case. You are rushing to the hospital and you are asking the nurse what the drug the patient has taken. And the nurse is telling you the name of the drug. Got it? Now you should be clear in your mind. Is it a drug which is having high plasma protein binding or low plasma protein binding? If it is having high plasma protein binding, don't instruct for dialysis. You can do other things, like you can do the gastric lavage, or if there is some antidote for that drug, you can try for other methods, but don't try for dialysis. That is the meaning. I hope you all are getting it. Can we go ahead? Can we go ahead? Yes. So coming on the next thing, listen, apparent volume of distribution. It is something very difficult. I want to explain you. Apparent volume of distribution. What is apparent volume of distribution? So can I tell you? Listen, just a second. It's difficult. Why it is known as apparent? It's not real. It's apparent. Listen. You tell me, whenever the drug is taken by oral route, it will go inside, and it will get absorbed. It will get absorbed. Once it reaches in the blood, what does it do? You will see, ma'am, it will move to multiple tissue. It will move to the multiple tissue. If I assume it don't go into the tissue, if I assume, although it don't happens in reality it will go. But if I assume it remains in the blood only. If I assume body is a homogeneous compartment, only one compartment is their blood. You tell me, if it is not going anywhere else, if I'm assuming it, it's not reality, I know. But if I'm assuming it is not going anywhere, it is remaining in the blood only. So tell me the concentration of the plasma which is required to hold the drug, which is required to accommodate the complete drug which I am giving, which is required to accommodate the complete drug. That volume of plasma is known as volume of distribution, apparent volume of distribution. Let me explain you with the help of an example. Let me explain you. Listen. So just suppose I am giving IV injection of a drug containing 1000 milligram. It contains 1000 milligram of the drug. How much? How much? 1000. So you'll say, ma'am, IV is there. So 1000 ka 1000, complete 1000 will go in the blood because it is IV. It is not oral. I will say, yes, the complete 1000 is going in the blood. So just suppose I am the patient, I am the subject. This is the injection. You have filled 1000 milligram of a drug and you are injecting inside me. So complete 1000 you have injected inside me. So in my blood, the complete 1000 is gone. Okay. Now immediately after that, you are taking a test tube and you are taking my blood sample. Okay. It is distributed everywhere in the blood. Now you are collecting the blood in a test tube and looking how much drug is present in my blood. And you got this value. You got in 1 liter, 50 milligram is present. How much? How much? For example, 50 milligram in 1 liter. So 50 milligram of the drug require 1 liter. So, but we have injected 1000 milligram. We have not injected 50 milligram. We have injected 4000. For 1000, how much liter is required? You tell me. Do the mathematics. Do the mathematics. Do the calculation. I mean, do you know? For 50 milligram, 1 liter is required. For 1000 milligram, how many liters is required, people? For 1000 milligram, how many liters is required? So you tell me 1000 upon 50, that is 20 liters. So for accommodating 1000 milligram, 20 liters of blood is required. You will say, ma'am, are you mad? Humans don't have 20 liters of blood. Humans have only 5 liters of blood. We all know that. Even a kid know that an adult human body have 5 liters of the fluid, 5 liters of blood. You are saying 20 liters is required. We don't have 20 liters. That's why I am saying, people, it's apparent. It's not reality. It's not reality. It's apparent. So you will say, ma'am, why in the calculation it is 20 liter? 20 liter never happens in reality. Why? Because I'm assuming there is no distribution. I'm assuming that. But in reality, it is distributed. So take the same example here. Let me explain you what is happening here. Why the answer is 20 liter. You are getting my point. Imagine. Listen, everyone. So I am giving 1000 milligram injection. Okay, the complete 1000 ka 1000 is going in the blood. You will say, ma'am, okay, you are giving 1000 milligram IV route. So complete 1000 is going in the blood. This is 1000 milligram. Now, out of the 1000 milligram, if I take the blood sample, in the blood sample, I got 50 milligram per liter. So if I calculate the volume to accommodate complete 1000, it should be 20 liter, because for 50 milligram, 1 liter is required. For 1000 milligram, 20 liter is required, but we don't have 20 liter. But actually, why it is 50? It should be 200 now. If instead of 50, if it is 200, you tell me 200 milligram per liter. For 200 milligram, 1 liter of blood is required. So for 1000 milligram, we have injected 1000. So for 1000 milligram, how many liter is required? You will see, ma'am, 1000 upon 200, that is 5 liter, and that is the correct calculation. I am having 5 liter of blood in me. So it should be 200 now. Why the answer is 50? If you're taking my blood sample, why it is 50? It should be 200. If I am having 5 liter of blood in me, it should be, answer should be 200. Why you are getting 50? Because remaining 150 is entered inside the site of action, inside the tissue. That is sequestered. This is known as sequestered hidden form that we are overlooking, that we are neglecting. That's why it's apparent volume of distribution. People say, respond. That's why it's not reality, it's apparent. We assume there is no distribution. I mean, the complete drug remains in the blood only, but that don't happen in reality. If the complete drug remains in reality, we require 20 liter, but we don't have 20 liter. But out of the 200, 150 is moving to the tissue. Only 50 is remaining in the drug, in the blood. And that's why the volume of distribution is 20 liter instead of 5 liter. People respond, say yes if you got it. This is the apparent volume of distribution. So how to calculate apparent volume of distribution? If you got it, it's very good. If you didn't got it, don't take stress, don't take load, learn the formula. This is the formula for volume of distribution. What is the formula of volume of distribution? It is the dose which is administered IV upon plasma concentration. This is how we calculate it now. I told you that the plasma concentration is 50. 50 milligram is present in 1 liter. 1 liter of plasma, 50 milligram of the drug. But we have injected how much? We have injected 1000 milligram. So what is the volume of distribution? You will see, ma'am, 1000 upon 50. 1000 upon 50, that is 20 liter. What is 1000? 1000 is the drug administered IV. And what is 50? 50 is the plasma concentration. So this is the formula of volume of distribution. People say, what is the formula of volume of distribution? Volume of distribution is equal to, what is the numerator? Numerator is the drug administered IV. And what is the denominator? The denominator is the plasma concentration. This is volume of distribution. Say yes if you got it. Say yes. So this is the formula of volume of distribution. Got it? Please learn it. Please learn it thoroughly. So this is the formula. Now what is the use? You will say, ma'am, how being a doctor it is related to me? Is it necessary to understand and learn? Yes, it is necessary. You tell me the drug which is having high bound form. Plasma protein binding is high. So free form is less. Free form is less. Free form is the plasma concentration. I'm considering plasma concentration as the free form. So free form is less. So plasma concentration is less. So volume of distribution will be more. And the drugs which is having less plasma protein binding will have the drug which is have less plasma protein binding will have high volume of distribution. So that is the implication. Okay, so we are done with this. Okay, so can I start the third chapter, metabolism? So distribution was really difficult. Here I taught you the concept of plasma protein binding, based on which I taught you the drug in the blood occurs in two forms: the free drug and the bound drug. Two type of drugs are there. The free drug is the active. It shows its mechanism of action. It is the drug which is metabolized. It is the drug which is excreted. Bound form neither show mechanism of action, nor metabolized, nor excreted. It is only the reservoir. The free drug decide the onset of action of a drug, and bound form decide the duration of action of a drug. So we have understood the concept, and after that we have understood one main concept, volume of distribution. I'm trying very hard to explain you. Give a gesture that you got it. Write down something. You got it? Can we go ahead? So we are done with 2 chapters till now. Can I start the 3rd chapter? Are you energetic till? You have to show your energy. If you want my energy touching the sky, you have to replicate that. Okay. So we are done with absorption. We are done with distribution. Let's start the 3rd chapter, metabolism. Let's start it. What do you mean by metabolism? What do you mean by biotransformation? Let me explain you. Listen. The drug is taken by oral route. It is going inside. It got absorbed. Acidic from the acidic medium, basic from the basic medium. In the blood, there is free form, there is bound form, whatever. We have understood that. And it has already shown its mechanism of action. Mechanism of action I will teach you in the next session. That is pharmacodynamics. That I will teach you in the next session. Now, drug have already performed its duty, its responsibility, its job. Now, drug want to excrete out of the body. Drug want to get, so drug is going to the kidney and asking the kidney, can you please excrete me? I have already performed my function. I want to go out of the body. So kidney is saying, no, I cannot excrete you. Why? Why you cannot excrete me? Because the kidney is saying you are a non-polar drug. Non-polar means not water soluble. I will excrete the drug in the urine. Urine is water. So you have to be water soluble. If you're not water soluble, how I will dissolve you in the urine and get out of the body? You have to be water soluble. If you want to get excreted from kidney, if the drug want to get excreted from the kidney via urine, it has to be converted from non-polar to polar first. So the kidney first go to the liver and ask the liver, can you please convert me from non-polar to polar? Liver is saying, yes, I can do so. Come inside me. Come inside my hepatocyte. There are enzymes inside my hepatocyte that will do so. So you will get converted from non-polar to polar, and after that you go back to the kidney and you will get excreted. So this is how the things happen, and this is known as metabolism. So metabolism takes place in liver. Where does the metabolism takes place? Metabolism is also known as biotransformation. It takes place in liver. So here we are doing certain alteration in the structure of the drug, so that ultimate purpose is we want to convert it from non-polar to polar. Say it in a different language. What do you mean by non-polar? Or what do you mean by polar? Non-polar is hydrophobic and polar is hydrophilic. You know, phobia means fear. Phobia means fear, and philia means love. So water fearing to water loving. I mean water insoluble to water soluble. So in a different language we are saying. And we know the lipid and water are inversely proportional. So we want to convert it from lipophilic to lipophobic. These all are your MCQs. What is the definition of biotransformation? You get confused in your exam. What is biotransformation? Can you define biotransformation, people? Biotransformation, also known as metabolism. What do you mean by that? Tell me three definitions. Say, ma'am, conversion of the drug from non-polar to polar, number one. The same meaning. Conversion of the drug from hydrophobic to hydrophilic. So that is the meaning. Or converting the drug from lipophilic to lipophobic. Because the water and the lipid are inversely proportional, and you get questions on that. So you get confused in your exam that which definition is correct. These three are correct. And in the options, you sometimes get the reverse and whatever. They will twist and turn the question. Say yes. So this is how you have to approach. This is definition. You will say, ma'am, okay, got it. Okay. So that it can be excreted out of the body. Okay. Now you got this. Okay. Now, okay, let me come. How does it occur? Now the question, how? Ma'am, how does it occur? How you will convert a drug from non-polar to polar? Tell me the mechanism. So there are two mechanisms. There are two type of metabolism, or there are two type of biotransformation. There are two type of metabolism, two type of biotransformation. Phase 1, phase 2. Phase 1 is known as functionalization and phase 2 is known as conjugation. What do you mean by functionalization? What do you mean by conjugation? I will explain. Listen, let's take here phase 1. Let's take here phase 2. Let me draw a drug. This is a non-polar drug. I want to convert it into polar. This is also a non-polar drug. I want to convert it into polar. So by phase 1, how do I do so? By phase 1, if I'm doing so with phase 1, how do I do so? So, you know, inside the drug, we will expose certain functional group. You know, hydroxyl, sulfate, methyl, multiple functional groups are there. We will expose it. Because of exposure of these functional groups, functional groups, it will become polar. So from non-polar, we are converting it to polar by exposing the functional group. That's why this mechanism is known as functionalization. By this, we are doing the conversion from non-polar to polar. Ultimately, we want to convert from non-polar to polar. We are doing it by exposing the functional groups inside the drug, by doing certain chemical alteration. Say, got it? Now coming on phase 2. In phase 2, what do we do? Here also, I want to convert non-polar to polar. Ultimate purpose is same. I want to convert a non-polar drug to a polar drug. But how do I do so? Here, I'm not exposing the functional group. So what I will do, I will conjugate this drug with certain another compound. This compound is polar. You will say, from where you are bringing this compound? This is the endogenous compound present already in human body. It is polar. It is already polar. So when we are combining the two, this is a non-polar drug and we are making a conjugate with some polar endogenous compound. So this thing is known as conjugate, the combination of the two. Conjugate is polar. Conjugate is polar. You got my point? For example, there is a non-vegetarian and married with a vegetarian. So ultimately the combo become vegetarian. The both of them. The husband is non-veg and the wife is veg. For example, vegetarian. And after marriage, both of them in the same way. You know, one is non-polar, one is polar, but the combo become polar. You got my point? So just a example I have quoted for fun. It is nothing related here, but you can learn this reaction is known as conjugation. This is phase 2. It is known as conjugation. Ultimate conjugate is polar. So this mechanism is known as conjugation. So we are having two mechanisms by which we can convert a non-polar drug to polar drug. How we can do the conversion? In phase 1, we will expose the functional group, that is functionalization. And in phase 2, we will do the conjugation. Conjugation with whom? With whom? With an endogenous polar compound. That is phase 2. People respond. People say yes. That is phase 1 and phase 2. I hope you all got it. Yes. So that is phase 1 and phase 2. So ultimately, this drug is moving to the liver, and inside the liver only non-polar get converted to polar by one of the two mechanisms, either with phase 1 by exposing its functional group, or by phase 2 or by combining it, conjugating it with some endogenous polar compound. So phase 1 is of 5 types depending which functional group is exposed. Phase 1 is of 5 type and phase 2 is of 6 types, so total 11 type. Okay, what are the 5 type of phase 1? Oxidation, reduction, hydrolysis, cyclization, decyclization. You have to learn the names. These are the 5 type of phase 1. In all of them, a functional group is exposed. So inside the drug, we will expose the functional group so that it will get converted from non-polar to polar. And in phase 2, there are 6 types. How many types in the phase 2? In the phase 2, we are having 6 types. What are the 6 types of phase 2? We are combining it with certain endogenous compound now. So this is our drug, which is non-polar. This one is non-polar. We are conjugating this drug with certain endogenous compound. This endogenous compound is polar and we want to make the conjugate. The conjugate is the combination of the two. This is a non-polar drug and this is a polar conjugate. So ultimately the conjugate, the assembly is the polar. This is the thing. Now the 6 type which I am telling you, depending on the 6 type of compounds. In human body, there are 6 type of endogenous polar compound. So it's triple G SMA. Triple G SMA. What do you mean by triple G? Glucuronide, glycine, glutathione, sulfite, methyl acetylate. So which endogenous compound you are combining with the drug, depending on that is the name of that conjugation. So glucuronide conjugation, glycine conjugation, glutathione conjugation, sulfate, methyl acetylate, SMA, triple G SMA. So it is of 6 types. So what we have learned? So we have learned metabolism, also known as biotransformation. Okay, what do you mean by that? In short, it means to convert the drug from non-polar to polar. That is hydrophobic to hydrophilic, lipophilic to lipophobic. We got that. Now, how many type it is? It is of 2 types. Phase 1, that is functionalization, and phase 2, that is conjugation. Phase 1 is of 5 types. Oxidation, reduction, hydrolysis, cyclization, and decyclization. Phase 2 is of 6 types. What are the 6 types of phase 2? Depending on the conjugate which is formed. So there are 6 type of polar compound. GGG, SMA. It is glutathione, glycine, glucuronide, sulfate, methyl acetylate. Now maximum questions in your exam comes from acetylation. So you have to learn the examples of acetylation from which maximum question. Although you should learn the examples of all of them. So there is a table. I will provide that table. But you have to learn specially the examples of acetylation on which maximum MCQs come. So acetylation examples, I am having a mnemonic for you. What is the mnemonic? The mnemonic is CHIPS ABC. What is the mnemonic? The mnemonic is CHIPS ABC. Let me explain the mnemonic. The mnemonic is CHIPS ABC. So what is C? C is clonazepam. Clonazepam is a sedative. You know clonazepam is a sedative. H is hydralazine. Hydralazine is an antihypertensive drug. I is isoniazid. Isoniazid is an anti-tubercular drug. P is procainamide. It is an anti-arrhythmic drug. S is sulfonamide, dapsone. It's a type of antibiotic. Okay. A is acebutol. It's a beta blocker. Amiodarone. B is benzocaine and C is caffeine. Caffeine which is present in coffee. So CHIPS ABC. You get many questions on that. I will show you the questions also. You get many questions on that. CHIPS ABC. So these are the drugs which are metabolized by acetylation. That is phase 2. Phase 2 conjugation reaction. Phase 2 metabolism. Read the question. Tell me the answer quickly. Read the question and tell me the answer quickly. All the drugs are metabolized by acetylation except. Apply the mnemonic. Just now I taught you the mnemonic. What was the mnemonic? The mnemonic is CHIPS ABC. This is the mnemonic. So what is not coming in this mnemonic? You tell me what is not coming in this mnemonic. You tell me. I is definitely coming, I for isoniazid. H is definitely coming, H is hydrolyzed. Now what is P? There is one P also. Is it phenytoin or is it prokinamide? What is this P? So of course this P is prokinamide. Phenytoin is not coming in this mnemonic. So learning the full form of mnemonic is important. Otherwise you will get confused in the exam. What does the P stand for? Okay, so learn the full form. Okay, now coming on the mechanism of metabolism, which is very difficult to understand, but I will try my best and I will make a cakewalk for you. Listen. What is the mechanism of metabolism? As I told you, metabolism occurs in the liver. So this is the liver. So this is the blood vessel. This is the liver. This is the cell inside the liver. Okay. This is the nucleus of the hepatocyte. Okay. This is the hepatocyte inside the liver. This is endoplasmic reticulum of the hepatocyte. This is our drug, which is non-polar. It want to get converted into polar so that it can excrete out of the body. Its job is done, its responsibility is done, its function is done. It has already shown its mechanism of action. It want to get excreted. So it will go to the liver. Liver, please convert me from non-polar to polar. Liver is saying, yes, why not? Come inside me. So it is entering inside the hepatocyte. In the hepatocyte, there are two types of enzymes. Certain enzymes are present in the endoplasmic reticulum. Okay, these are known as microsomal enzymes. They convert the drug from non-polar to polar, and certain enzymes are present in the cytoplasm. These are known as non-microsomal enzymes. They also convert the drug from non-polar to polar. You will say, then what is the difference? Whether the drug get metabolized by microsomal or non-microsomal enzyme. Is it a difference? Yes, it makes a sense. It makes a sense when we give the combination of the drug. When we are giving only one drug, it's okay. But when we are giving 2, 3, 4 drugs to the patient, so microsomal enzymes are inducible as well as inhibited by other drugs. So drug-drug interactions are very common in microsomal enzymes which are present into the endoplasmic reticulum. Most common example here is cytochrome P450. Most common example. Others are also there, but most common is cytochrome P450. But the enzymes which are present in the cytoplasm, that is non-microsomal, these are neither induced nor inhibited by other drugs. So drug-drug interaction is not common. So you can give any two drugs together. There is no harm in that. But if you are giving the drugs which are metabolized by microsomal enzymes, you have to look for the combination. Being a doctor, we don't give one drug to our patient. Imagine a patient coming to your clinic. Patient, doctor, I'm having fever also, I'm having cough also, I'm having infection also, I'm having acidity also. You are prescribing drug A, drug B, drug C, drug. You are prescribing the drug. Okay, take all these. Okay, this is BD, this is TD, this is OD, this is HS, this is SOS, whatever. You are giving a combo. You are a cocktail of the drug. So you have to look for the interactions. You cannot give multiple combo cocktail, just mix them and give. No. Quacks do that, but an educated doctor don't do so. So we have to look for the combinations. There are certain combinations which are inhibited, so we can't give that combination. We have to understand it. So for that we have to understand the microsomal and non-microsomal enzymes. So there are two type of enzymes. The microsomal enzymes, they are present in endoplasmic reticulum of the hepatocyte, and non-microsomal enzymes, they are present in the cytoplasm of hepatocyte. Both of them are present in the liver, in the hepatocyte. These are inducible as well as inhibited by other drugs. These are neither inducible nor inhibited by other drugs. So here drug-drug interactions are there. Here no drug interactions are there. So these are safe. These are unsafe. So let me explain you with the help of an example. So we will understand microsomal enzymes which are present in endoplasmic reticulum. These are inducible also, inhibited also. Let's take the example of inhibition first, followed by induction. Please understand, it's difficult. Please understand. Now listen. In my clinic, there is a patient. Let's make a story. In my clinic, there is a patient. Patient is having certain problem for which I'm prescribing. I'm a doctor. I'm prescribing a drug to the patient. Patient is happy. Patient is taking the drug by mouth. The drug is going inside, getting absorbed, going in the blood, showing its mechanism of action. Patient is cured. Patient is treated. Now drug want to get excreted, but drug cannot be excreted. For that, the drug want to get metabolized because it is non-polar. So it is going in the liver and asking the liver, can you convert me from non-polar to polar? Liver is saying, yes, why not? Come inside me, my enzyme will convert you. My microsomal enzyme will convert you. So if you are giving only one drug, the things were very simple. Let me zoom this on the next page so you can see here. So you can see this is the liver I'm talking about. Inside the liver, have a look on the hepatocyte. Inside the hepatocyte, see the endoplasmic reticulum and see this purple color enzyme. Purple color. Till I was giving only one drug A, the things were simple. Drug A was going to the liver. Liver, please convert me non-polar to polar. And liver was happily converting the drug from non-polar to polar. The enzyme was happily converting. And the drug was very happy getting excreted out of the body. Things were super simple. There was no problem in that. Still, we were giving one drug. But now the twist in the story. Now let's make a twist in the story. We are not giving one drug. We are giving two drugs. We are giving drug B also. drug B also. And unfortunately, drug B is an inhibitor of this enzyme. Have a look on the minus sign. I have put a minus sign over here. Minus is inhibition. So drug B is inhibiting this enzyme. This enzyme is non-functional. This enzyme is non-functional. Now drug A is coming and asking the same question. Liver, can you convert me from non-polar to polar? Liver is saying, no, I cannot convert you. I cannot convert you, dear. Why? Because my enzyme is gone. Initially, I was having the enzyme, but there is a drug B, that is inhibited my enzyme. So I don't have any enzyme. So how can I convert you from non-polar to polar? You remain non-polar only. I cannot convert you to polar. So this drug cannot be excreted out of the body. It will remain inside the body only, and it will lead to toxicity. So my point is that whenever you are giving these two drugs, drug A is causing toxicity. Drug A is known as substrate drug, and drug B is known as inhibitor drug. Red and green. Red is the substrate, B is the inhibitor. How many of you getting it? How many of you getting it? Huh? Say yes. I'm reading your query. Wait a while. Rajput, what you are asking? Give me a minute. Let me finish this. Then I will read your query, what you are asking. Okay. So drug B is the inhibitor drug. Got my point? Okay. So whenever we give this combination, being a doctor, we should know this combination. We don't give this combination. So this is a list of drug A, the substrate drug, the object drug. Drug A, the red drug. And this is a list of drug B. Drug B, the green drug, the inhibitor drug. Never give them together. Never give. If you give them together, what will happen? There is toxicity of the substrate, not of the inhibitor. So patient will have toxicity of this. Patient will have adverse effect and toxicity of this. Don't give this. If you are giving this, reduce the dose of it. If at all, if you are giving. So being a doctor, being a good doctor, you should know the combination and you have to avoid the combination. So substrate drug, I'm having a mnemonic to learn. The mnemonic is CT scan. How many of you got it? Huh? How many of you got it? Give me a thumbs up. So it will be excreted slowly, Gauri, not very fast. You know, the enzyme is inhibited, but it is not 100% inhibited. Maybe few percentage is still remaining. That is causing the excretion of the drug, but it will be a slower process as compared to normal. Being a doctor, I am not assuming that. Just suppose, there is a patient in my clinic. I am a doctor and I am giving the combination of any two the drug. Maybe I am giving this with this, this with this. I am giving any two this combination, and I have not, I have forget this list. And I'm not very a good doctor, for example, and I don't know this inhibition and this mechanism. I'm giving any of the two combination. So patient will come to me with the toxicity of these drugs. I cannot afford that. So either I will avoid this combination. In case if I can't avoid it, it is necessary to give any of the combination of the two list. I will reduce the dose of the A. Being reduced of the dose of the A, it will show the same action. I hope you are getting it. So learn the list. Learn the two lists. Never give them together. Never do such a mistake. Never give these drugs together. So the mnemonic for the substrate drug is CT scan. CT scan. That is the mnemonic. C stand for two things. CCB, calcium channel blocker, and cyclosporin. T for tacrolimus. S for statins. You know, drugs to reduce the cholesterol in the blood. C, one more C is there. Cisapride. Okay. A is amiodarone and N is Navarus. You know what is Navarus? Navarus are the anti-HIV drugs. They are used in HIV treatment, AIDS treatment. These are protease inhibitors. Navarus. Okay. So never give these drugs with these drugs. What is the mnemonic for enzyme inhibitors? I'm having a mnemonic again. Vitamin K cannot cause enzyme inhibition. So the mnemonic also contains inhibition. You can remember the mnemonic. V stand for valproate. K stand for ketoconazole. C stand for simantadine. One more C stand for ciproflox. E stand for erythromycin. I stand for INH, that is isoniazid. Now imagine a patient who is having HIV and TB together. I guess everyone knows HIV patients are high prone of developing TB because they are immunocompromised now. So for HIV, Navarus are already going on. And for TB, isoniazid we are giving. We cannot give this combination. If you can't avoid, reduce the dose of Navarus. How many of you are getting it? Say yes. Say yes. So never give CT scan. Never give CT scan with vitamin K cannot cause enzyme inhibition. Learn the full form. Avoid this combination. Red alert. If you don't avoid it, there will be toxicity of the substrate drug, not of the inhibitors. People respond. People say yes if you got it. Say yes if you got it. Huh? Can we go ahead? Say yes. So that is the enzyme inhibition. Now let's do the reverse. So what is happening in the enzyme inhibition? In the enzyme inhibition, you have to learn there is toxicity of the object drug. Toxicity of the object drug. Now let's do the reverse. Let's do enzyme induction. Let's do enzyme induction. If I'm giving only one drug to the patient, drug A, the red drug. If I'm giving only red drug to the patient, drug A. I'm giving only one drug. Very simple. Things are super simple. I wish if we could give only one drug to a patient, but patient don't take only one drug. We have to give a cocktail. Patient is having this also, this also, this also. We give multiple drugs. If we give only one drug, things are very simple. It gets absorbed. It shows mechanism of action. It is going to the liver and liver converting it from non-polar to polar. I'm zooming this on the next page. So on the next page, you can see if it was only drug A, The liver was converting it from non-polar to polar happily. And after getting converted to polar, it was excreted out of the body. Things were very simple. Everyone was very happy. But now we are not taking one drug. We are taking another drug, drug B. Drug B also, which is an inducer. Notice the plus sign. It's not minus, it's the plus sign. Have a look on the plus sign. Have a look on the plus sign. Okay, it is an inducer. It is inducing the enzyme. What do you mean by inducer? It increases the activity of the enzyme. It increases it, the enzyme becomes hyperactive. You say, ma'am, what is the harm in that? The enzyme is becoming hyperactive. So I want this enzyme. This enzyme is present here. This enzyme is present here inside the liver. Okay, I want this enzyme to convert my drug from non-polar to polar. I want this to be active. But after it has shown its mechanism of action, then only I want this conversion so that it is excreted out of the body. Now here the enzyme become hyperactive because of drug B. It becomes hyperactive. So before drug A, my drug A shows its mechanism of action, it get converted from non-polar to polar and it is excreted. So drug will not show its action, or drug's efficacy will be reduced. So instead of toxicity, here reduced efficacy is there. So it's reverse. How many of you getting it? So got my point. So that is enzyme induction. So here the drug efficacy is reduced. So here there is no toxicity. The drug efficacy is reduced. So efficacy of A will reduce. If you are giving it with B, B is an inducer. So never give the substrate drug with the inducer. Substrate drugs are same. That is CT scan. The same CT scan. Never give them with inducers. I will give you a list of inducer. They induce the enzyme. Never give them together, because if you give them together, the substrate drug will show reduced efficacy. It will not show toxicity. This time it will show reduced efficacy. So CT scan is same, but you have to learn the list of enzyme inducer. What is the mnemonic here? Enzyme inducer. The mnemonic is GPRS, cell phone battery dead. So G stands for rhizophlavin, it's an antifungal drug. P for phenytoin, it's the anti-epileptic drug. R for rifampicin, anti-TB drug, anti-leprosy also. S is smoking. C for carbamazepine, again anti-epileptic drug. P for phenobarbital. B for barbiturate, which is a barbiturate, a type of barbiturate is phenobarbital, and D for DDT. So please learn the full form, people. You can't expect how many questions you get from this topic. You can't expect in your exams. Please understand. So being a doctor, you should know the three list. So this is a substrate drug, CT scan. Never give them with inhibitor. Never give them with inducer. Avoid this combination. You should know the cross. Avoid this combination. Neither give them with inhibitor nor give them with inducer. So whenever any patient come to you, make a habit. Ask what all drugs you already taking. Show me your file. Show me all the drugs you are taking. So have a look on all the drugs the patient already taking. If any drug is from this list, be careful what additional drug you are giving. So never give this drug or never give these drugs. If you are giving the substrate drug along with inhibitors, so patient will have toxicity of the substrate drug. And if you are giving the substrate drug along with inducers, patient have reduced efficacy of the substrate drug. So it is the substrate drug which is suffering. It is not the inducers and the inhibitors. I don't know how many of you got it, but I tried my best. If you got the concept, if you appreciate the efforts which I'm putting to explain you, give me a thumbs up, people. I mean, give me any gesture that you got it. Write down, give me a thumbs up. Give me some emoji that you got it. Show me your happy feeling, happy faces that you got it. Say yes. Yes, can we go ahead? So that is enzyme inhibition, enzyme induction. So never give CT scan. Never give CT scan with what and with what? Never give CT scan with enzyme inhibitors. You know what are enzyme inhibitors? What are enzyme inhibitors? Vitamin K cannot cause enzyme inhibition. I assume you know the full form. And never give CT scan with enzyme inducer. What are enzyme inducer? What are enzyme inducer? Tell me the mnemonic. GPRS, cell phone battery dead. Learn the full form. So whenever you prescribe CT scan to any patient, learn the full form. So always be careful. Never give this, never give this. That is the summary. Got it? Got it. Now, listen. Hoffman's elimination. You say, what is this terminology? Hoffman's elimination. Only one drug shows this. Let me explain what does it mean. Let me explain. Now imagine a drug. The drug taken again by oral route, going inside, getting absorbed, reaching in the blood. Now this drug is non-polar. Okay, it has already shown its mechanism of action. Okay, it is non-polar. Now it want to get excreted, but this drug is very egoistic. Some people are very good. The drug do not want to go to the liver and do not want to take the help of the liver enzyme. The drug do not want to take the help of liver enzyme to get converted into polar. Drug do not want to take anyone's help. Drug is saying, I will convert to polar by my own, without the agency of enzyme. I do not take the help of liver enzyme to help me to convert from non-polar to polar. I do it by my own in the blood itself. So how the drug do so? The drug will do certain three-dimensional stereotypic molecular rearrangement inside its structure and get converted from non-polar to polar. Self-dependent drug. It will not use the help of the enzyme to convert it from non-polar to polar, the liver enzyme. So this is known as Hoffman's elimination. Only one drug does so. Only one drug is very self-dependent. Etracurium is the name of the drug. You get many questions on that. You get many questions on that. Believe me, people, believe me. Believe me. Say yes. Huh? So etracurium. So it is the spontaneous molecular rearrangement in the blood itself, which convert the drug from non-polar to polar without the agency of any enzyme, without the help of any enzyme. That is Hoffman's elimination. We are done. Okay, so read the question, tell me the answer. We are done with metabolism also. Now read the question and tell me the answer. Please read the question and tell me the answer. All are enzyme inhibitors except. Which of the following is not enzyme inhibitor? Which of the following is not enzyme inhibitor? Read the question and tell me the answer. Is it carbamazepine, simantadine, valproate, or ketoconazole? What is the correct answer, people? What is the correct answer? Is it carbamazepine, simantadine, valproate, or ketoconazole? Please write down your answer in the comment box. Yes? Gauri, Bisma, Ima, Saddam. I cannot see the names. Anshika. Everyone? Yes. The correct answer is carbamazepine. Absolutely right, Gauri. Absolutely right, Jitan. Absolutely right, everyone. So we are asking about enzyme inhibitors. These all are enzyme inhibitors except. So the mnemonic is vitamin K cannot cause enzyme inhibition. The simantadine is coming in this mnemonic. Valproate is coming in this mnemonic. And ketoconazole is also coming in this mnemonic. But carbamazepine is coming in the inducer, not inhibitor. Carbamazepine is one of the inducer, not inhibitor. So you can solve it very easily. You get very simple question on this list. You have to learn the three mnemonic thoroughly in your mind. Which of the following drug is the enzyme inducer? So apply the mnemonic GPRS, cell, phone, battery, dat. What is coming in this mnemonic? Of course, you can say R for rifampicin. So R for rifampicin is definitely coming in this. The correct answer is rifampicin. So in the same way, you can apply the mnemonics and you can tell the answer. One more last question here. Hoffman's elimination is what? Can you tell me what is Hoffman's elimination? Yes? What is Hoffman's elimination? Can you tell me the answer? Yes, what is Hoffman's elimination? Read the four options. Is it inactivation of the drug by metabolizing enzyme? Is it unchanged drug excretion by the kidney? Is it excretion in the feces? Or is it inactivation by molecular rearrangement? What is the correct answer? Yes. Quick, fast. What is the correct answer? Yes. It's inactivation by molecular rearrangement. So in a three-dimensional structure, the drug is doing certain molecular rearrangement in its structure without the use of enzyme to get converted from non-polar to polar. And only one drug does so. That is etracurium. Got it? So we have completed three important chapters in pharmacokinetics: absorption, distribution, metabolism. The last chapter is excretion. You still want me to complete? It's already 12 at India, I mean here. So I don't have any problem. I can continue. You show your interest. You want me to complete it? So the last portion, excretion. Can I continue? Are you people still energetic? So let's continue. So let's continue with the excretion of the drug, the last chapter. So pharmacokinetics, one shot, it will be completed. So let's start excretion. Let me warn you, it's difficult to understand, but let me tell you something. It's very interesting if you understand. And if you don't understand now, it will be a bouncer. It will be a simple bouncer. So I request all the students to please concentrate. Listen. So last step, excretion, but it's very difficult. So last step coming on the excretion. What is excretion? It is the passage of the drug out of the body. The drug is already polar now. The drug is already absorbed. It has already shown its mechanism of action, that is, it is distributed. It is already converted from non-polar to polar. We have seen enzyme inducers, inhibitors. Now it's time to excrete the drug. Excretion is going the drug out of the body. So the drug is passing out of the body. So it can pass 99% in the urine via kidney, but rarely it can. Some drugs are excreted in feces, via lungs, that is exhalation. We inhale and we exhale. So in exhalation also some drugs are passed. and excreted out of the body in saliva, sweating, breast milk. But most common way of excreting the drug is urine. So we will understand the urine. Humans have a pair of kidney. We all know humans have a pair of kidney. We all have a pair of kidney. Inside the kidney, we have nephrons. Nephron is the structural and functional unit of the kidney. In one kidney, we have 1 million nephrons. So all the healthy human beings have 2 million nephrons in 2 kidneys. One kidney, 1 million nephron. This is the diagram of a nephron. To understand the excretion of the drug via urine, via kidney, renal excretion, you have to understand nephron. So in the nephron, there are 5 parts. What are the 5 parts of nephron? This is Bowman's capsule. This is proximal convoluted tubule. This is loop of Hanle. This is distal convoluted tubule. And this is collecting duct. So that is, so here the most important thing for us to understand is the glomerulus. So let me zoom the glomerulus on the next page. Let me zoom. So this is the glomerulus. So there is a Bowman's capsule. I hope you all can understand this is Bowman's capsule. Can you see this is Bowman's capsule? See, this is Bowman's capsule. Now have a look. The afferent arteriole is coming here. Afferent arteriole is coming, going inside the Bowman's capsule, making a tuft of capillary here. It makes a tuft of capillary and coming out as efferent arteriole. Okay. Now whatever substances present in the blood which are supposed to get excreted, they will pass from here and they will accumulate in the Bowman's capsule. Okay. So this is known as glomerular filtration. What does it is known as? Glomerular filtration. I will tell you the details. Okay, it is not the final, it is excreted in the urine. No, many exchanges still takes place. This is glomerular filtration. Now the afferent arteriole, I repeat, the afferent arteriole is coming. The afferent arteriole, this is known as afferent arteriole. I guess you have studied all this in physiology, in pathology. The afferent arteriole is coming here. Okay, making a tuft of capillary and moving out as efferent arteriole. Okay, afferent is coming, making a tuft of capillary, moving out as efferent arteriole. What happens to this efferent arteriole afterwards? So here also you can see this is the afferent arteriole which is going inside, making multiple tuft of capillary and moving out as efferent arteriole. Once the efferent arteriole is out, it will make a peritubular capillary. So it will divide it over the tubules completely and cover these tubules. So by tubules, I mean PCT, loop of Hanle, DCT, and collecting tubule. So peritubular capillaries are formed. So why I'm insisting on the peritubular capillary? Because I will explain you something here. Now come on the topic, that is excretion. Let me explain you the excretion. If you got this, let me explain you the excretion. So let me explain you the renal excretion. What is the net renal excretion? So there are 3 steps. There are 3 steps in net renal excretion. Please understand, it's difficult, I'm warning, but it's very interesting if you understand it. It will be like, cakewalk for you if you understand. So there are 3 steps: glomerular filtration, tubular secretion, and tubular reabsorption. We add these 2. And from the summation of these 2, we subtract the reabsorption. You will say, ma'am, what does it mean? I don't understand anything. It's okay. Let me explain. Let me handle this. Now, can you see this diagram? In this diagram, first you appreciate the Bowman's capsule. Please understand, this is the master diagram in which I will explain you the complete process of excretion right now. Please understand this diagram, the master diagram. Can you see this is Bowman's capsule? Let me explain you. This is the Bowman's capsule. You all can see. I'm highlighting the boundaries of the Bowman's capsule. This is Bowman's capsule. Okay. Now this is the afferent arteriole which is coming here. Afferent arteriole. It's coming here. Okay. And it is forming a tuft of capillary and moving out as efferent arteriole. This is afferent arteriole forming a tuft of capillary, you can see, and moving out as efferent arteriole. And after efferent arteriole, it is forming the peritubular capillary on the PCT. You can see this is PCT, no? Proximal convoluted tubule. This is PCT. So this is forming a capillary around it. So listen. Listen my point. 3 things happen. What are the 3 things happening? Number 1. Here, whatever drug is present, you can see the drug here. Drug is present in the blood. No, it is coming from the efferent arteriole in the capillary. First, it will show glomerular filtration. So first step is glomerular filtration. Number 1. After that, the drug is present here. It will reabsorb and go in the blood back. A proportion of that. That is known as tubular reabsorption. And after that, a proportion is again secreted here. That is known as tubular secretion. Look at the arrows. So whatever after these 3 things is remaining here, that is excreted in urine. So look at the arrows. 2 arrows are coming inward, 1 is going outward. Out of the 3 things. What are the 3 things first you learn? What are the 3 things first you learn that? So the 3 things is glomerular filtration, tubular reabsorption, and tubular secretion. Look at the arrows now. So drug is coming. Drug is coming in the blood from the glomerulus. So here it is adding in the urine. drug is getting reabsorbed in the tubules, it is subtracting from the urine. And again, it is coming in the urine by tubular secretion. So we add glomerular filtration plus tubular secretion. We add the two things and we subtract tubular reabsorption from the summation. First, you tell me how many of you got this addition and subtraction. Then I will give you the detail of the 3 steps. First, you tell me how many of you got the arrows, got the meaning of the arrows here. How many of you? Shall I repeat? If even a single student say repeat, I will repeat. First, you say you got it or you didn't got it. I want each and every one of you to understand this. So 3 things are happening. Look at the arrows again. I'm repeating. Listen. First thing, here is the drug. First, you understand here is my drug. Okay. The drug is coming out of the capillary and getting accumulated in the Bowman's capsule. This is known as glomerular filtration, number 1. So you can see it is adding in the urine. It is adding. Then after coming here, it is there in the Bowman's capsule. It is there in the PCT. It will get reabsorbed in the blood. So it is subtracting. It is known as tubular reabsorption. It is reabsorbed. No, it is subtracting from the urine. And after that, it is here in the blood now. And after that, it is coming back in the urine. This is known as tubular secretion. So again, it is adding in the urine. So my point is that out of the 3 things, 2 are adding in the urine. Glomerular filtration and tubular secretion. Look at the arrows. They are coming in the urine. And one thing is subtracting from the urine. That is tubular reabsorption. So finally, which drug is excreted in the urine? What is excreted? So it is the summation of glomerular filtration plus tubular secretion. From this, I will subtract tubular reabsorption. This is the formula of excretion. How many of you got it? I guess most of you. Okay. Now, things were simple till now, people. Let me twist and turn now. Hannah, let me come on the twist and turn of each of these 3 things. Tell me the factors of each of these 3 things. So this is the formula for the excretion. First, understand the formula. It's glomerular filtration plus tubular secretion minus tubular reabsorption. From the summation of these 2, we will subtract the tubular reabsorption. Now, we will see the detail of these 3 one by one. First of all, I will tell you the detail of glomerular filtration. Then I will come on tubular reabsorption. And then finally, I will come on secretion. So we will see the factors affecting each of them. Let's start the first one, glomerular filtration. Rather than reading, we will see in the diagram. Listen, now, you know, I have told you that in the blood, the drug occurs in 2 forms. What are the 2 forms? The drug occurs in the blood. See, it is the free drug. Can you see? This is the free drug. And it is the bound drug. The bound drug is bound to the protein. So in the blood, both are present. Both are present. Okay. So the blood is going in the capillary. You can see in the blood, the free drug is also present. The bound drug is also present. Can you see the lining of the capillary? It is by endothelial lining. Can you see? These are the endothelial cells lining the wall of the capillary. So can you see there is a gap between the endothelial cells? Between 2 adjacent endothelial cells, there is a gap. Have you read pathology? See my lectures of pathology also. See, there is a gap. There is a gap between the 2 endothelial cells. Can you appreciate the gap? Now the gap is very small. So you tell me using your common sense that out of the 2 drugs, free drug and bound drug, which will cross the gap? You tell me. Obviously, free drug is very small because it is free. So it can cross this gap and come in the filtrate. It can come in the filtrate. It will show the glomerular filtration. But bound is big in size because it is bound with the protein. So it cannot cross the gap. So it cannot come in the glomerular filtration. So how much drug will cross and come in the glomerular filtrate? It depends on plasma protein binding. So the drug which is having more free form, so it will come more in the glomerular filtrate. And the drug which is having more bound form, it will not come in the glomerular filtrate. So it depends only on one factor, and the factor is plasma protein binding. So glomerular filtration depends on plasma protein binding. I want to teach you 3 things. Now people, one by one, I will explain you all. So I'm teaching you the factors of the 3. So the only one factor of glomerular filtration is plasma protein binding. If the plasma protein binding is more, I mean bound form is more. So bound form is more. So glomerular filtration will be less. If the plasma protein binding is less, I mean the bound form is less. I mean the free form is more. So glomerular filtration will be more. No need to learn. Everything is conceptual and you have to understand it. You have to understand it. Say yes. Anna, got it. So this is about the glomerular filtration. It don't depend on lipid solubility. It depends only on plasma protein binding. So we are done with 1. So we are done with 1. Here only one factor. Plasma protein binding. The proportion of free drug and bound drug will decide. The proportion between them, that will decide. So we want more and more free drug. More and more free drug is there, more and more filtration will be there. If bound form is more, filtration will be less. Obviously, because bound is bigger in size. It cannot cross the gap between the capillary, between the endothelial lining of the capillary. Okay, G. Okay, let's come on tubular reabsorption. tubular reabsorption. Then in the end, we will see the secretion. Now, let me tell you the factors of reabsorption. It is difficult. It's very difficult portion of the entire chapter which I have taught you. This is the most difficult. So let's come on the reabsorption. So here only one factor, plasma protein binding. Here we have two factors. Here plasma protein binding doesn't matter. Here lipid solubility and ionization of the drug. These are the two factors which will decide the reabsorption of the drug. So it depends on two factors, lipid solubility and ionization of the drug. The two factors are there. One is lipid solubility and one is ionization of the drug. Let me explain you one by one. Listen, till now this is the summary. Till now this is the summary. Say yes. Huh? See, this is free drug. This is bound drug. Okay, you all can see that. Free drug, all the free drug have crossed the filtration barrier and it has already came into the filtrate. It has already accumulated in the Bowman's capsule and PCT. Bound drug do not cross. What happens to bound drug? That may be coming a question in your mind. You will say, ma'am, how the bound drug will be excreted? I will tell you later on. Wait, I will tell you later on what will happen to this. The story of the bound drug, I will tell you later on. In the third step, in the tubular secretion, I will tell you. Currently, the free drug is already in. The free drug is already in. Now, there are two possibilities. This free drug can be lipid soluble, can be lipid insoluble. Hana? This free drug can be lipid soluble, can be lipid insoluble. It can be anything. Imagine this free drug can be lipid soluble, can be lipid insoluble. If it is lipid soluble, these are the lining of the cell, of the tubule, of the PCT. If it is lipid soluble, it will cross the lining and it will move back in the blood. Lipid soluble will move. But if it is lipid insoluble, it cannot cross the lining and it will be excreted. So lipid soluble will be reabsorbed. It will go back in the blood. It will diffuse back in the blood. Because it is lipid soluble, it can cross the cell. But lipid insoluble cannot cross the cell. So it has no option. It will excrete in the urine only. How many of you are getting it? Please, if you don't get it, tell me frankly, without hesitation. I will repeat 1,000 times if you don't get it. Please understand it. Okay. So this is the free drug you can see. It can be lipid soluble. It can be lipid soluble. Two options are in front of you. If it is lipid soluble, it can cross the cell membrane and it will go back in the blood quickly. And if it is lipid insoluble, it cannot go back. So only option, it will be excreted in the urine. So first factor is lipid solubility. Lipid solubility. You understood. So it's easy. I guess it's easy. Lipid soluble, it will go back and it will not come in the urine. Lipid insoluble, it will come in the urine. So if you want to excrete the drug, make it lipid insoluble so that it can be excreted. And if you don't want to excrete the drug, it should be lipid soluble. It will be reabsorbed. It will not come in the blood. It will not come in the urine. It will go back in the blood. Second factor. First factor is lipid solubility. Okay, I'm teaching you tubular reabsorption. First factor is lipid solubility. Second factor is ionization and anionization. Now again, this is the free drug. Free drug is already there. Bound drug is not coming in the filtrate. 100% free drug is coming here. This is the free drug. Now there are two options. This is free drug. We all can see this is free drug. It can be ionized. It can be unionized. I told you, how many of you are attending the lecture from the beginning since last 2-3 hours? How many of you? So if you're attending the lecture in the beginning, you may be knowing, I told you at the beginning of the lecture only, body don't like charge. Body excrete ion and body retain the unionized form. Body absorb unionized form and body excrete the ionized form. So out of ionized and unionized, body don't like charges. No? Ions are excreted, but unionized body will take back. So tubular reabsorption takes place of the unionized form. That will not excrete it. It will go back in the blood. That will remain in the blood. But the ionized form will be excreted. That is the second thing. You are getting it. The second factor. So the tubular reabsorption depends on two factors. Lipid solubility and ionized and unionized. You got my point? I will again try. People, let me summarize. Then I will try. Listen. Now you will saying, ma'am, who will decide what is the percentage of the drug ionized and what is the percentage of drug unionized? Listen. How much percentage of drug is ionized and how much is unionized? Is it 90 and 10 or is it 10 and 90? Who is going to decide that? It is deciding the pH of the urine. The pH of the urine. Okay, let's complicate it. pH of the urine. So at the beginning of the lecture only, I told you for excretion, opposite pH is required. Do you know this funda? If you want to excrete acidic drug, take the urine, make the urine basic. So in basic urine, it will be excreted because in basic urine, it will be ionized and ions are excreted. And if you want to excrete the basic drug, make the urine acidic. Because in acidic urine, the basic drug will be ionized and ions are excreted. So this is the funda I have explained you at the beginning of the lecture only. Okay, so I am just revising it here. So imagine my drug is basic. So what do you want? I want to excrete a basic drug. Imagine my free drug is basic. It can be acid. I will take both possibilities. So imagine my drug is basic. You can see it here very well. My drug is basic. I want to excrete it. So what pH to the urine I should provide? So I should make the urine, my drug is basic now, I should make the urine acidic. If I'm making the urine acidic, the opposite pH, so 99% it will be ionized and only 1% it is unionized. So 99% it will be excreted and 1% will be reabsorbed. It will be like that. Got my point? And imagine if my drug is acidic. It's not basic. Imagine if my drug is acidic. My drug is acidic. Okay. So I want to excrete it. I want to excrete it. It has already performed its function. I want to excrete it. So what is the pH of the urine I should provide? I should provide opposite pH. So for excreting acidic drug, I should make the urine basic. I should make the urine basic. Okay. So in basic pH, in basic acidic drug in basic pH, again 99% will be ionized and 1% is unionized. So 99% will be excreted and 1% is reabsorbed. So you get many complicated MCQs on that. Got my point? Okay, so that is the thing. So that we have learned. So what we have learned, can you summarize till now? So there are 3 factors on which renal excretion depends. So glomerular filtration depends on plasma protein binding. Okay, it depends on the proportion of the free drug and the bound drug. Plasma protein binding is the bound drug. If the bound drug is more, the glomerular filtration is less. And if the bound drug is less, free drug is more, so glomerular filtration is more. Because it is the size of the drug that matters, that can cross the gap between the endothelial cells of the capillary. Okay, now we have started the tubular reabsorption. Here 2 factors are important. One is lipid solubility and one is ionized and unionized form. So in the lipid solubility, we are having 2 possibilities. Lipid soluble, lipid insoluble. Lipid soluble are reabsorbed and lipid insoluble are excreted. In the ionized, unionized also we have 2 possibilities, ionized and unionized. Ionized form are excreted and unionized form are reabsorbed. So that is the thing you have to understand. Rather than learning, you have to understand. And ionized and unionized, we can make it by changing the pH of the urine. And if you want to excrete, you have to provide opposite pH of the urine. Coming on the last thing, tubular secretion. The last thing is tubular secretion. Now, there may be a question in your mind that, ma'am, you told us there are 2 types of drug, free drug. And ideally, this question should be asked by you, not by me. You should ask this question. Ma'am, there are 2 types of drug, free drug and bound drug. You told us that 100% free drug is coming here. It is getting filtered and coming here. This is known as glomerular filtration. But bound drug is not coming. So what happens to the bound drug? You forgot the bound drug. No, I have not forgot. So this bound drug is going ahead, and it is going in this capillary. So this is my bound drug. So here only 100% bound drug is there. Free drug is not there because free drug is already coming here. Free drug is not there, but there is an equilibrium in the free and bound. I told you, now bound is acting as a backup. Since free becomes 0, the bound get converted into the free. The bound get converted into the free here. The bound get converted into the free in this peritubular capillary. And this free drug will come back into the tubule using a transporter, which is present in the cells of the tubules, in the cells of the PCT or tubules. So this is a transporter. So this transporter will carry the free drug here and it will transmit it here. This is known as tubular secretion. Look at the arrow. It is added in the urine. So bound drug, which was escaping here, which was not coming here, it was escaped. It was escaped here. That bound drug convert into the free drug, and here it is coming back into the urine. That is known as tubular secretion. How many of you got it? How many of you got it? You may be asking, you should ask one more question. Ma'am, why this conversion not taking place here only? You are converting it here in the capillary. Why you are not converting here in this loop only? Because here blood flow is very fast. There is no time of conversion. And here blood flow is sluggish. Here blood flow is sluggish. So there is a time for conversion. So there is an answer for every query. But the thing is, you should ask the question. You are not asking the question. So that is the summary. So here the third step. This one depends only on one thing, transporter. So this depends on the transporter. So here I have written the factors of all 3. So what is the revision? What is the summary? We are done with excretion. We are done with excretion. What we have learned? We have learned the excretion of a drug depends on 3 factors. What are the 3 factors? Glomerular filtration plus tubular secretion and minus tubular reabsorption. I hope you can understand it. Now tell me the factors of each of them. Glomerular filtration depends on plasma protein binding. You can understand that. Tubular reabsorption depends on 2 things. Lipid solubility, whether soluble or not soluble, and ionized and unionized form, whether ionized or unionized, and you know the summary. Okay. And tubular secretion depends only on transporters, the organic transporters. I tried my best. To explain you the complete excretion process. This is the summary. All 3 steps are shown to you here. You want me to summarize the three. You can see this is the bound drug, this is the free drug. In glomerular filtration, only free is coming, bound is not coming. You can see once the free is there, now it is lipid soluble or insoluble. If it is insoluble, it is excreted, soluble is absorbed. It is ionized or unionized. Unionized is absorbed, ionized is excreted. This is tubular reabsorption. And after that, the bound is moving here and bound is converting into free, and free via using organic transporter, it is coming back in the urine. This is known as tubular secretion. So really, I tried very hard to explain you the process of the excretion. So we have completed the entire pharmacokinetics, people. I taught you 4 chapters here. I taught you entire absorption, entire distribution, entire metabolism, also known as biotransformation, and entire excretion also. How many of you got it? Was the session useful for you? Was the session useful for you? Say yes, say no, respond, say something. So let me announce my next session, then you people can go. So I would like to stop here. Thank you so much for your patience, for your cooperation, and for your precious time you are giving. Thank you so much. So if you have any query which I have taught you today in this session, if you have, or any other session which I have taken on the YouTube, so you can text your query. Don't call, please. This number is for text support, for the chat support. So you can text your query on this number. The number is 9833032948. I personally respond all the queries. Maybe there is a delay of 1 or 2 days in response. I cannot respond immediately if I'm busy, but definitely you will get a response for your query, whatever is your query. So if you have any topic in your mind that you want me to take on YouTube, maybe the topic is from patho, pharma, micro, PSM, medicine, so I will schedule that topic soon. If many students are demanding the same topic, you can text that topic also on this number. Thank you so much, and we will schedule it soon, the topic. If you want the notes of this session, so just after ending the session, not right now, in the session only, in the chat box, in the comment box, you will get the link which is pinned. You just click on the link and you will get the notes. That's absolutely free. And not only this notes, all the notes of entire YouTube session you will get there. So you can do that after the session. Here is the QR code. You can scan this QR code. If you are scanning it, you will be diverted towards my website, that is MedLive by Dr. Priyanka, and through which you can connect with me with various social media platforms on which daily I share high yielding content for the medicos. So I share the updates, and if you are interested, you can do so. So that's all about it. Thank you so much. If you like the session, don't forget to click on the like button before leaving. Subscribe the YouTube channel, press the bell icon, and please share the link with all the medicos throughout the globe. Please, it's a free education, and we want to give it to everyone who deserve it and who can understand it and who want the most simplified version of these subjects. So thank you so much. Yeah, my next session. So this is the sessions for the February, for the month. So today we have complete pharmacokinetics in one shot. Now the next session is on 23rd of February. That is a topic from the PSM, that is triage. Now on 25th, instead of 25th, we have changed the date to 27th. On 27th of February, complete mycology in one shot. On huge demand of student, I have scheduled this session, the complete fungus in one shot. And finally on 29th, the last day of the month, there is a session on thalassemia. The timings of all the session is same, night, 10 p.m. Okay, thank you so much for being with me. Don't forget to share your valuable feedback with us. Thank you so much. Your feedback really matters for us. Thank you so much. Good night. All the best. Bye-bye. If you have any query, don't hesitate to ask. So text it, the number provided. And if you have any topic in your mind, please share the topic. We will schedule it soon on the YouTube. And please share the link of these sessions to all your friends, colleagues, medicos throughout the globe. Thank you so much. Bye-bye. Good night. I'm ending the session.